discrete immune system to protect the life or organ. Modern science says fever is immune response against infection. If fever is immune response against infection, temperature of fever is not a surplus temperature. It is not supposed to be eliminated from the body. If we try to eliminate the immune response against infection, the infection will increase. It is dangerous to immune system. It is necessary to protect immune system to increase essential blood circulation. Never allow body temperature to lower by atmosphere. A brooding hen's body temperature increase like that during fever to increase essential blood circulation in the body. The brooding hen does not eat any food. Brooding hen's food is its heat, which help to convert fat into energy. Many people who have a misconception that fever should be cured or changed. It is not the fever that need to be cured or changed. It is the disease or cause of disease that need to be cured. Fever is an adaptation only. Fever can be compared to our soldiers. Sometimes our patriotic soldiers may be defeated, surrendered, or even die. It is not due to the anti-national activity of our soldiers. New fever definition. If essential blood circulation decreases to organs, reveals a sensible and discrete action of immune system to increase essential blood circulation as a self-defense mechanism of the body to sustain the life or organ. We can answer almost all the questions about a fever with this definition. If we avoid or evade from this definition, we will never get a proper answer to even a single question. Next point is, what is the temperature of fever not above 42 degrees Celsius? This is the most important question. To know the answer to this question, you need to know what the temperature of fever is for. When our body is over 42 degrees Celsius, our immune system knows that vitamins, proteins, and other elements will lose their proper form and perish, and need up to 42 degrees Celsius to save life and organs until the last minute. So, immune system create temperature below 42 degrees Celsius. When the hen is brooding, the temperature of hen does not exceed the limit because hen's immune system produces heat with a clear purpose. Once that purpose is accomplished, that increased heat will disappear or the production of that extra heat will stop. Similarly, our immune system created temperature below 42 degrees with the clear intention of saving life or organs until the last moment. Once that is accomplished, our immune system will stop overheating. The temperature of the fever increases in proportion to the increase in inflammation in our body and the decrease in blood circulation. Inflammation is a condition in which the temperature of fever increases as a blood circulation decreases. Similarly, as the inflammation decreases and the blood circulation increases, the temperature of the fever decreases. Next point, the heat energy used for which activities in fever and hyperthermia? Increased blood circulation to most important organs. In disease increased fever, the activity of most important organs increases and the activity of less important organs decreases. This is not due to the increase in temperature. It is due to decreasing essential blood circulation. This is like an inverter used to work most essential lights and machines in an emergency due to power failure. During fever, body increases activities of most essential organs like brain, heart, kidney, and liver. Uncontrolled temperature can occur in heat stroke. It is not below 42 degrees. Moreover, it was not created by specific purpose. When our immune system does not things like water sponging that reduce the temperature of fever, the body resists and hates it. The body never liked the temperature of heat stroke. And body likes all the activities like sponging with water that reduce the temperature. When there is a fever, the body like and upset the temperature up to 42 degree from outside and inside to the body. Similarly, the truth can be identified by examining the body's aversion towards temperature above 24 degree when there is no fever. Why do fever have symptoms, signs, signals, and actions? Fever is an action that has symptoms, signs, signals, and actions. Keeping the temperature below 42 degrees Celsius is just an act of fever. Another action of fever is the action of TNF alpha, a chemical that causes bitter taste and decrease appetite. Why does not everyone with the decrease, why does not everyone with the disease have a fever? Three reasons. The virus, bacteria, and etc. does not cause fever in everyone because the cause of disease does not decrease essential blood circulation to organs. Next point, the body does not need fever protection. Third point, the immune system does not have energy to produce the temperature of fever as in AIDS. How can create a fever and hyperpyresia and fits within hours? In people with tonsillitis, children, and the elderly, using ice water, we can create a fever and hyperpyresia within a few hours. With the continued use, we can cause death in them. Talaikuttal is the best example. Talaikuttal. Talaikottal is the traditional practice of sanicide, killing of the elderly, or involuntary euthanasia by their own family members observed in some parts of Sadet. I have called, sorry for bear with me. By their own family members observed in some parts of southern districts of Tamil Nadu, state of India. This is a process in which an extensive bath is given to an elderly person before the crack of dawn. He or she is given several glasses of cold tender coconut water and head massage with cold water. By doing this, the temperature of the body falls suddenly and causing high fever, which leads to the death of old age person within 1 or 2 days. Please look to the reference number 9, 10, and 11. Similarly, in COVID patients, using sponging with ice water, we can create a fever and hyperpyresia within a few hours. With the continued use, we can cause death in them. Prolonged exposure to water can cause fever. How another important question is in here, how unscientific is it to say that you can change that fever by dipping water in your body? Some thought-provoking questions and answers. First question is, if pouring cold water on the body can reduce body heat and cause fever, hyperparesia in Talaikottal, cannot any disease cause fever and hyperpyresia by pouring water on the body? The answer is can. Next question is there any difference between a fever caused by Talaikottal and other illness? The answer is no. Next question is there any difference between fever, fits, and death due to heat loss in Talaikottal and fever, fits, and death due to heat loss in COVID-19? The answer is no. Next question is there any difference between COVID-19 fever treatment and Talaikottal fever treatment and any other fever treatment? The answer is no. Is conservative fever treatment suitable to Talaikottal? The answer is no. In Talaikottal, what are the necessary ingredients to cure hyperpyresia? There is another question. To increase blood circulation and to decrease inflammation, heat supplementation is necessary and prevent heat loss from the body. Next question. If fever with Talaikottal can be cured with heat, can fever with any disease not be cured with heat? The answer is can. Next question is, if water in the body can reduce the body temperature and cause fever, then water again can reduce the temperature of the body and cause fits and death as in Talaikottal. If modern fever treatment can be done by sponging or immersing the body in ice water or hyperpyresia, can it cause fits and death by reducing the body temperature? The answer is can. Most medical books says that patients with hyperpyresia should be immediately immersed in ice water regardless of the cause of disease. According to this, the patients with hyperpyresia due to Talaikottal, does immersion in ice water cause death? The answer is there will be death. Another question isn't the signs of fever, fits, and death in Talekuttal the same as the signs of fever, fits, and death in other diseases? The answer is yes. Next question is, will existing fever treatment reduce COVID death? No. Next question, did any patient die without developing a fever in COVID-19 and without a heat reduction treatment for that fever? The answer is unlikely to occur. How unscientific it is say that prolonged exposure to water can cause fever, and that fever can be cured by sponging in water. Fever is measured with the thermometer, and the hypothermia is measured with the same thermometer. This is purely unscientific. The basic elements necessary for a scientific treatment is not provided in fever treatment. Next point is, how can we prove that the temperature of fever is to increase essential blood circulation? First point is, if we ask any type of question related to fever by assuming that the temperature of fever is to increase essential blood circulation, we will get a clear answer. If we avoid or evade from this definition, we will never get the proper answer to even a single question. Next point, if we do any type of treatment by assuming that the temperature of fever is to increase essential blood circulation, the body will upset at the same time. Body will resist whatever treatment to decrease blood circulation. Next point, if you measure the heat energy used for which activities in fever, we will know the purpose of the temperature of fever. It is astonishing that modern science has not been able to examine what actions with the heat energy of fever despite its advanced development. No further evidence is required to prove the temperature of fever is to increase essential blood circulation. Apart from this, what kind of evidence is needed to prove that the temperature of fever can increase blood circulation? Let me know new parameters to prove the purpose of temperature of fever. We can prove that the temperature of fever is to increase essential blood circulation with that parameters. Fever is it a protector or destroyer of brain cells? First point is, will temperature of fever protect brain cells by increasing essential blood circulation to the brain, or will it destroy brain cells? Delirious fits formation in this is fever. When disease increases, essential blood circulation and energy level also decreases. The vertical height between heart and brain is more than 1 feet. When the disease becomes severe, ability to pump blood to the brain decreases. Then blood flow to the brain decreases and delirious or fits are formed. As a result of this, brain cells are damaged, so the patient might be paralyzed or may even die. Fever and delirium. Fainting or delirious or damage to the brain cells is not due to the increased temperature of fever. It is due to decrease in blood circulation to the brain. Without knowing the purpose of fever and without examining what actions were taken with the heat of fever, it is said that fits or delirious would happen due to increasing temperature of fever. Temperature below 42 degrees never cause any harm to our body. During summer, in some parts of India, atmospheric temperature is more than 45 degrees. If atmosphere temperature is below 42 degrees, as in hyperpyresia, there is no such a history of one have been affected with delirious or fits. At sauna temperature ranges from 160 to 200 degree Fahrenheit. In a steam bath, a person being 15 to 25 minutes. Sorry for having some cold. While taking a normal steam bath, the temperature inside the bath is more than 50 degrees centigrade. There is no such a history one had fainted or affected with the delirious or fits. During fever, if take steam bath, fits never happens, blood circulation never decreases, skin never shrinks as in fever. Signs of curing fits. Regain consciousness even before the temperature subsides. When a fainted patient lies on the floor, the vertical height between heart and brain decreases. So blood circulation increases to the brain, and the fits is cured even before temperature subsides. Many people misunderstand that regained consciousness is due to the reduction of temperature. Shivering is to increase blood circulation. Hyperpyresia temperature is below 42 degrees Celsius. Only 4 degree increase in body temperature. If a 4 degree increase in temperature occurs, there is no history to show that shivering occurs. If disease increases, blood circulation decreases. Shivering is not due to increase in fever, but due to increase of disease, decrease of energy, immunity power, strength, essential blood circulation, etc. Shivering helps to increase heat. Then essential blood circulation will increase. Fever and shivering are protective actions according to the aim and the target of immune system. If body produces excess amount of heat, energy, or force, strength, the body will never shiver. During fevers, one shiver due to lack of enough temperature in shivering area. In other words, if a body has enough temperature to maintain its normal body temperature, it will not shiver. The disease of, the decrease of essential blood temperature. Temperature of sustained life is the cause of shivering. In fever condition, how much essential temperature is decreased in the body, corresponding temperature is produced to generate counterbalance of the decrease in essential blood circulation. Animal behavior advantage instinct. Buffaloes does not try to enter or lie in water nor drink it during fever. Buffaloes manage body temperature by immersing their body in water and drink it. But when they are having fever, they do not try to enter the water nor drink it. Ways to eliminate fever by increasing blood circulation. Just listen to the messages from the body and act accordingly. Increasing blood circulation is a right treatment for fever. Blood circulation never increases without increase in temperature, which can never be cured without increase in essential blood circulation. To increase essential blood circulation, never allow body temperature to loss via atmosphere and apply extra heat from outside and inside to the body. It will help the immune system to fight against infection. Blanket, steam bath, hot sandbag, thermal heat pad, hot pepper water, hot drinks can be used. Mechanism of application of heat. When the temperature produced by the body due to fever and heat which we applied on the body combines together, the essential blood circulation increases. Then immune system will stop to produce heat to increase essential blood circulation. And the body will get extra heat from outside without any usage of its energy. Heat is the fast and efficient way to reduce inflammation and increase blood circulation. During fever, 99% of disease of patient shows inflammation. Apply heat from outside and inside to the body. Blood circulation and inflammation related to fever and its signals, symptoms, signs, and actions will decrease. Then essential blood circulation increase, inflammation decrease, digestion increase, body pain diminishes. Like and upset hotness. When we apply heat from outside and inside to the body, all the signals, symptoms of fever, like and upset the hotness according to the directions and commands of immune system. If fever is immune response against infection, our body like and upset hotness. At the same time, our body dislike and hate temperature reducing methods. If fever is immune response against infection, temperature of fever is not a surface temperature. If we reduce temperature by water sponging, infection will increase and it may be dangerous. Fever is not a part of disease, it is a part of self-defense mechanism of the body and it is an adaptation. A disease does not require fever, but at the same time, fever requires a disease. Both the disease and fever are different. We cannot include body destructing disease and body protecting fever in the same group. Conservative fever treatments and its effects. And medical books says our understanding of the neural basis of thermoregulation fever is still rudimentary. Fever treatments, roller sponging and paracetamol. Whatever happens to a brooding hen and its egg, if sponged with water, the same happens to a fever patient if temperature is decreased by sponging. The same thing happens in Thalekuthal. The researchers found that the glutathione level were lower when single dose of paracetamol was used. This may increase the inflammation level. Removal of temperature of fever by sponging or paracetamol is not helpful for curing disease. It is believed that the doctor will save the patient in the treatment of fever, but the doctor becomes the executioner who kills the patient. All the conservative treatments for fever not only do not make a radical cure of the feverish condition, but also further decrease essential blood circulation and increase inflammation, and leads to body more dangers. The best way to reduce COVID death rate is ban conservative fever treatment in Thalekuthal model. The temperature is decreased by sponging or paracetamol. Disease or cause of disease or cause of fever is never decreased. It is proved that fever medicines are more dangerous than disease and fever treatments are more dangerous than medicines for fever. A lot of problems emerges not knowing the purpose or temperature of fever. It may cause death, various hypotheses, contradictory definitions, contradictory fever treatments, etc. The result of not knowing the purpose or temperature of fever. Contradictory fever treatments, various types of sponging. Some physicians recommend sponging with water. Some other physicians are recommending normal water. Some physicians recommend sponging with ice water. Most medical books say that patients with hyperpyresia should be immediately immersed in ice water regardless of the cause of disease. If patient is shivering, all the physicians recommend hot water sponging. Most patients are troubled when they are having hyperpyresia. If the temperature of fever is surplus temperature or it is supposed to be eliminated from the body, the ice water is must to reduce body temperature. If fever is immune response against infection, never use temperature reducing methods like sponging. Use of ice water is a modern version of Talekutal. If fever is body's own disease fighting mechanism, how does various types of water helping doing it? Another question. Contradictory definitions can be seen in various medical books. One medical book says fever disturbs homeostasis. Other medical book says body is on disease fighting arsenal, beneficial effects of fever, the adverse effects of fever, fever increase immunity power, fever decrease immunity, all are seen in various medical books. If fever disturbs the homeostasis, fever is always dangerous. So it is eliminated from the body. If fever is immune response against infection or body is on disease fighting arsenal or fever increase immunity power, it is always good to the body. Next point is contractive fever treatments, cool air. Some physicians instruct you use cool air or air conditioner or fan. Some physicians prohibit to use air conditioner or fan. Everyone in the ICU uses air conditioner. If the temperature of fever is surplus temperature or it is supposed to be eliminated from the body, air conditioner is must to reduce body temperature. If fever is immune response against infection, never use fan or air conditioner. Never allow body temperature to lose by atmosphere. Another point is contractive fever treatments, blankets. Some physicians instruct to use blankets. Some physicians are prohibited from using blankets. If patients in shivering with shivering, all physicians tell the patient to use blanket. If temperature of fever is surplus temperature, never use blankets. Blankets increase the body temperature. If fever is immune response against infection, always use blankets. Contrary fever treatments, drinking water. Some physicians instruct to drink hot water. Some physicians recommend to drink cold water. If patient is shivering, all physicians recommend drinking hot water. Most patients rebel when they have hyperpyresia. If temperature of fever is surplus temperature, always use cold water or ice water. Never use hot water. It will help to increase body temperature. If fever is immune response against infection, always use hot water. After analyzing and evaluating statements and correlate them, it becomes clear that what is right and what is wrong. Besides that, it was found that all the statements in the medical books were contradictory, leading us to utter confusion. A science cannot have such a conflicting practices. If you read the contradictory definitions and treatments in front of a rock statue, it will start to laugh. Is there any based conservative fever treatment? No. All the treatments of fever are based on the belief that fever temperature between 38 to 41 degrees harm to brain and body. At the same time, there is no concrete evidence to this belief. Next point is the purpose of rise of temperature is not known. Without knowing the purpose of temperature of fever and without examining what action was taken with the heat energy of the fever, what science can be used to say that fever is dangerous? Hitherto, the aim and target to rise of temperature in the case of fever has been subject to innumerable research work by lot of medical universities of international repute. But unfortunately, modern medical scientists have concluded that the purpose of rise of temperature could not be found. The importance of the finding of the purpose of temperature in fever in COVID-19, immediate relief from fever and body pain, life-saving discovery, a single magic answer to every fever-related questions. If medicines are prepared according to the purpose of temperature of fever, any country can guide the world in the cure for fever. Conclusion. When the disease becomes threatened to life or organ, the temperature of fever in COVID-19 is to increase essential blood circulation. Its delirious or damage of brain cells are not caused when an increase in temperature of fever takes place. It is due to decrease in blood circulation to the brain. Apply extra heat from outside and inside to the body will increase blood circulation. Conservative fever treatment should be revised according to the sensible and discrete action of immune system. There is only one way to reduce COVID death. Prohibit Talekutal model conservative fever treatment. There is no other way than this. It is wonderful that a physician having years of experience in fever treatment cannot understand actual purpose of temperature of fever. Thank you hearing me patiently so far. Please check 9 reference number 9, 10, and 11. This belongs to the Thalai Kutal. I have another paper also. After some time, I will the purpose of the fever is not a symptom. COVID-19 will present after some time. You can ask any questions to my WhatsApp number or email ID. Thank you hearing me patiently so far. Hello. Hello.
Yes, thank you. Thank you. Excellent presentation. Any questions from participants? Okay, no problem. We will share Dr. Yakub mail ID. Dr. Yakub, you have another presentation. After 1 or 2 speakers, I will you can continue with your next presentation.
Okay. After 2 speakers, I will continue. I have a call also. That's the problem.
Sure. Thank you for the Amelia, can you read the next speaker biography, please? Sorry, Waha, are you online?
Yes, I am.
Yes, I am.
Yes. Can you read the biography?
I'm sharing my screen.
Speaker, just a minute. Our moderator will give short biography about you. Just wait 1 minute.
Okay, so I can start now?
Just wait a minute.
Yeah. Hello, everyone. Thank you for the privilege.
We're going to share your biography and read it.
You can hear?
Yes, doctor, we can hear you. We're just going to share now the biography and read it, and you can start your presentation.
Okay, thank you.
Thank you.
So, hello, everyone. It's not my screen. Hello, everyone. Thank you for the privilege to share what's happening in the schools in Hong Kong under the pandemic. And this is the outline of my presentation. I would like to talk about the impact of COVID-19 on school life and what measures can be taken place in school, and also the multi-level strategies to minimize transmission of infection in school setting, and also how would school build up a sustainable system to combat infectious disease and also future health. So when COVID-19 happened a year ago, more than a year now, so most governments around the world have temporarily closed educational institutions to contain the spread of COVID-19 pandemic, and it affects over 250 million learners. And lack of the connectivity has become a leading factor of the exclusion. And 1/3 of the students could not access remote learning solutions, even in Hong Kong. And while 40% of the poorest countries could not support the most disadvantaged to learn during school closures. And this caused for reflection on broadening the scope of the right to education. And the right to education has become increasingly dependent on connectivities, making digital inclusion a key to leaving no one behind. So it is very important. And what happened in Hong Kong then? The impact of COVID-19 on school life in Hong Kong. We have done student health survey. This is a self-administered online survey. And we've done it to 11 secondary schools with over 1,000 students interviewed from secondary 1 to secondary 3, and they're about age 12 to 14. And we have done a pre-test in September 2019 and a post-test in August 2020. And we also done survey in the 5 primary schools with about 385 valid questionnaires collected from the primary 6 students. So they are around age of 11. And the pre-test is done in February, and we have done an interim in February 2019, and a post-test in July 2020. The findings from the secondary schools that we found the proportion of students engaged in the 60 minutes moderate to vigorous exercise decreases from around 40% to under 30%, and many of those that taken in groups or in public. And also the proportion of students spending time on various types of electronic media, not for the purpose of academic purpose, has increased. And it increased the impact of concentration, emotional, and back discomfort. And the proportion of students going to bed after 11 p.m. has increased over 10%. And the proportion of students getting up around 8 a.m. increases nearly 30%. And detailed findings, we also asked the students what have been changed in their hygiene practice, exercise habits, and eating habits during this pandemic. And 54.9% of students reported obvious change in hygiene practice. And 24.2% of students report obvious change in exercise habit, and 17.5% of students report obvious change in eating habits. And we'll see some details. For hygiene practice, we asked questions about wearing masks, washing hands, covering toilet seats before they're brushing, and the steps of hand washing, changing clothes and doing laundry, and the cleaning the household. And we can see that it's increased the number of times of wearing masks. Then over 90% of students say they will wear masks. 80% of students say they increase the times of washing their hands. And about 60% of students, they say they will cover the toilet seat before brushing. And about 55% of students will say they follow the steps of hand washing instead of just wash it like roughly or like not really paying attention. And also around 50% of students say they will increase the frequency of changing their clothes and doing the laundry. And for cleaning the household, about 40% of the students say they will increase the number of cleaning the household. For the exercise habit in the secondary school, we have asked them what have they done in running and walking, playing ball games, exercise at home, and some water games, or doing some outdoor activities. And we can see there's decreased number of students that can do the running and walking because with the we don't have a lockdown in Hong Kong, but we have highly recommended to stay home during the outbreak. So 52.8% of the students say they have decreased the running and walking. And also more than 40% of students, they say they have decreased playing ball games. And around 40% of the students say they do more exercise at home because we recommend to stay home. And exercise that they can do at home is skipping, stretching, and some muscle training. And also there's a decrease in the water games because most of the facilities, public facilities is closed during the outbreak. And an increase of outdoor activities, only 16% say there is increase, but around 11% of students say there's a decrease in the outdoor activities. And for the eating habits, we ask them whether they eat at home or they have consumed more fruits, more takeaway, and consumption of soft drinks, dessert, crepes, and also consuming of water. And we found that 55% of the students, they eat more at home. And also around 40% of the students say they have more fruits at home. But in a way, they have more takeaway food. Around 30% of students say they have increased the consumption of takeaway food. And also increased the amount of taking soft drinks and also eating desserts and crepes. And some students found that they have decreased consumption of water when they stay home. And from the primary school, in the respect for consumption of vegetable and fruits, 47.2% of students consume at least 2 portions of vegetables and 71.3% of them consume at least 2 portions of fruits. But still, it is not a number it doesn't meet the sufficient number that we have recommended they have fruits and vegetables. And the number of students who took less snacks significantly decreased in the second year, 91%, over 90% of students consumed crispy snack for less than 4 times a week. And an improving trend was also observed for consumption of candies and chocolates that like 83.1% have ate candies and chocolates for less than 4 times a week. And considering the habits of physical activities, because they are recommended to stay home, so they can't do much. And the survey showed that there has been a significant higher portion of students doing exercise for like 3 to 6 days, reaching in the second year. But in the third year, that is the time that we have the outbreak of COVID. Due to the lengthening home time during the pandemic, the proportion of students who could achieve the amount of exercise recommended by WHO is like 60 minutes a day for 4 days a week. It decreased to 10%. Only 10% of students can do the exercise at home. So we can see the COVID-19 has bring a profound change in also in social behavior, besides the physical and the physical health. So it's the dramatic shift of sleep, substance use, physical activities, and diet have subsequent downstream mental health consequences. And the social isolation brings a range of psychological harms, example, depression, anxiety, and stress. This is funding for other study. And also the prevalence of depression symptoms among people adopting low healthy behavior, that means low healthy eating behavior and not regular exercising, was reported to be 2.7 times higher than those adopt for combined healthy behavior. That's being physically active, and they're long smoker and moderate alcohol consumer, and having adequate fruit and vegetable intake. And the physical activities alone can be an important factor in reduction risk of developing depression. And a study from another physician in Hong Kong, Dr. Ben Fong, said 65.3% of the participants experienced increased stress during the stay home, because we stay home for so long, and 29.7% experienced moderate to severe level of depression symptoms. And the increase in the use of electronic devices and the decrease in outside activities were positively associated with a higher level of depression severity. So we must not forget about the increasing physical activities and maintaining healthier diets can lead to a positive change to their physical health, and also associate with not only being better physically fit, but also better mentally fit. And we need to create more open public space that will facilitate social interaction for the students and still allow adequate physical social distancing. So for the national guideline that we have, like around most countries, they recommend physical distancing. They recommend wearing face masks and hand hygiene. And also they recommend to lobby support for implementation with consultation and joint planning. And they also recommend to ensure adequate local supply of basic protective measures. And also the communication between different stakeholders to keep them safe in the pandemic. So what's happening in Hong Kong then? In Hong Kong, we also recommend to facilitate within the locality for isolation and quarantine, and deploy adequate manpower resources for efficient implementation of guidelines. And we recommend to work with local community leaders and local key stakeholders to create social norms to compile with various preventive measures. And also the project planning to meet the local needs is very important. And also to enhance social harmony and social connectedness, because most of the people, especially students, they're recommended to stay home. And it is also very important to strengthen the communication between the community parties. So what can we do to minimize the spread of infection in school settings? For first thing that we can do, it will be an early alert of infected cases. The home monitoring of body temperature is very important whenever they need to go to school. they have to check their temperature before they go to school. If they got fever or they got other sickness, they shouldn't go to school. They should stay home and seek doctor's advice. And the health declaration of symptoms subjective of respiratory infection is important. Also, the checking of body temperature upon entry of school premise is very important too. So in Hong Kong, most of the school, they have installed a temperature check at the entrance. And alert of developing symptoms during school time. So if the student feels sick at any time during the school time, they should tell the teachers. And close communication with local doctors to manage students with symptoms. Also, the precaution of positive cases is also important too. So those with fevers and with bad cough or bad runny nose or severe sore throat should follow medical advices before returning to school. And those with mild symptoms should first consult doctor to certify they're fit for school and maintain a distance with like 1.5 meter between each other, and face mask should be wear for all time. History of the traveling to high-risk area within the last 14 days should stay home until lapse of 14 days. And I think we have increased it to 21 days now, like if they come from the high-risk area. And those with the history of close contact with confirmed or suspected cases or cases with fever and respiratory symptoms should follow medical advices before they return to school. We also have to maintain the hygiene environment in school. So they have to wear face masks all the time in school, and hand hygiene are basically effective precautionary measures against influenza and respiratory infections. Adequate hand washing facilities and hand sanitizers and spare face masks should be provided in school. And well ventilation classrooms and adequate spacing should be provided. And avoid non-essential large group activities and make use of open areas. And also consider some teaching online and face-to-face in small groups. So, and avoid close body contact activities. So in Hong Kong, like most of we are back to school after the Easter holiday, and only like we accommodate 50% of the students that they can be back to school for half day, so they don't have lunch in school. So we reduce the time that they need to take off their mask, and also we keep the capacity to be lower. And we also have to monitor the absence, like proper sick leave record for students and staff to be kept. And so local health authority can be alert for unusual patterns and follow up for those absence of their progress and positive diagnosis, so that close contact can be alert to be observed. Our center has implemented health promoting school for more than 2 decades. And how we could use the health promoting school framework to tackle infectious disease control, this is what we can done here. So in the health in school settings, where we have to set up like different healthy school policies with those with disease, with those with illness, and also we have to working with local doctors for prompt advice on what we can do if there's an outbreak, or there's a confirmed case, or there's any other things related to medical issues. And for the physical environment, we have to reinforce the personal hygiene. The students should wear masks all the time. The students should wash their hands with sanitizer, and also the students should keep a safe social distancing in school. And also the maintenance of hygienic school environment is important. So we have guidelines for the janitors, how many times they have to, how often, how frequency they have to clean up the school, and all rooms should be cleaned after they use before the next group of students they come. And also we recommend the student, they don't go get into the same area at the same time. So we give less time in between that the place can be clean. And for the social environment, we have to create a social norm for appropriate level of risk perception. that the student should know that what to do and what should not be done, so to protect themselves and also protect others. And for the community, it is very important to have a mutual sharing of knowledge, skills, and resources during the health crisis. And also, it is very important to equip the students that they know to enhance the health literacy and life skills in self-care and self-management during this health crisis. So during the past 15 months of COVID-19, so we have on and off like physical class, and we also have hybrid mode, and we have tried so many different things in school. And teaching and learning have been conducted online for most of the time. And we have some small group of students, as I said before, that they go back to school to have interaction. And it is important to cover health and well-being while student learning taking place at home. Because when they are staying home for a very long time, it's kind of like stressful for the students. And also for some students that they don't have a very good connection on internet, it also affects their learning. And during the recovery phase from pandemic, building up the resilience for students, staff, and parents are also very much needed. And our Center for Health Education and Health Promotion is making use of the existing online platform of GoSmart channel. We have currently most of our videos is in Cantonese, and this cover like different kind of like social well-being, societal health, and also personal development. And our center is also in progress of creating special corners of COVID-19 sharing with students and parents on videos enhancing healthy living during the pandemic. And our center also prepared a guidebook on community action and COVID-19. So this is, you see the link on my PowerPoint that you can come and start, give a simple registration, then you focus on school settings too. This is the GoSmart channel that I shared in the last PowerPoint. It was launched in April 2018, and we have over 800 video clips available in the channel right now with over like 150 health resources. And most of them are in Chinese. We have about 20, like we got English subtitle in this channel, and it covers like 6 categories, like health promoting school good practice, healthy body in youth, positive mind in youth, social well-being in youth, and youth theater and health promotion in society. And this channel can be viewed like on computer and also on mobile phone. So see you if you have any questions. And thank you for listening.
Thank you, Dr. Emily, for such informative presentation. Thank you so much. So anyone has a question for Dr. Emily? Okay, seems there's no question, but let me read the biography to let you know who's Dr. Emilia. Emilia is Health Promotion Consultant, Health Promotion Officer, IC of Center for Health Education and Health Promotion of CUHK. She has been involved in health promoting school movement in the past 2 decades in the center, developing HSP performance indicator and international benchmarking system. She was extensive experience in advising schools to successfully build a healthy and safe school environment. She has been involved in conducting HPS capacity building workshop for educators and health professionals. Her research interests are HSP, emotional well-being, and child and adolescent health using different qualitative methods, including photo voice, focus group, and interviews, and quantitative methods. So you are so welcome, Doctor, and thank you so much.
Thank you.
So now let's welcome the next speaker, Dr. Francis, or Francis Greenwald. He is an agricultural engineer. He has been working for more than 35 years in the solidarity sector after various positions at UN, ICRC, and NGOs.
Do you see me?
He was CEO of the group URD before becoming director of. Yeah, welcome, Francis.
Yes, I'm trying to open it.
I'm reading your biography now, so yes, I'm going to continue.
Okay, go ahead.
Yeah, he leads research and evaluation for humanitarian programs and risk management, preparedness in Africa, Latin America, the Caucasus, Asia, and the Middle East. For donors, Red Cross, UN, and NGOs, associate professor at the University of Paris, and lecturer in various institutions in Europe, as well as in Canada and the United States. He is also author of numerous articles and editors for several books. He is currently in the charge for COVID-19 Observatory. So you are so welcome, Doctor, to start.
Yes. Do you hear me?
Yes, we can hear you.
And do you see me?
Yes, we can. You can share your slide.
Yeah, just I had a computer crash this morning. That's why I had difficulties to join you, and I don't know what happened with my presentation. It kind of get spoiled. So I will do it live without PowerPoint. It will be a bit of a change, but we can still do it. So my presentation will be based on research we have done over the last year or so on managing this COVID situation. And the title of the presentation is "The Lesson Learned That Have Not Been Used." And it is based on the first piece of work we did early in March last year that you can find on our COVID Observatory. I will put the link.
Hello, Doctor, can you share your presentation? We are unable to see your presentation.
Do you hear me?
Can you share your screen, please?
Yeah, I'm trying to do that. I have some technical difficulty. Oh, yeah, I don't know what's happening. I don't know. Hop.
Okay. If possible, can you share your PPTs to our mail ID? We will display your PPT. No problem.
So I'm trying to get that.
Okay, you can continue now.
So the one I want to share is this one. Talk. Yeah, I can start with this one. Do you see it?
Yes, we can see it. Yes.
Okay. So this was a study we did in March 2020. So a year ago, where we tried to review all the lessons that have been learned from the different missions we did on Ebola and cholera and all kind of diseases. So we tried to put on one short document all the key lessons learned that were developed over the years on mega health crisis management. And what we did after, and I will go to another document. What we did after is we went to, so let me just see if we can change it. So I will go to change again. We went on the second document, which was a review 1 year after of all the lessons that were taken earlier and that were not heard, that were not taken on board, and in fact the type of action that should have been needed, taking into account the lesson learned from earlier large-scale health crisis. So we will go to a few points. One is a bit an introduction of the method. The second one will be the critical presence of health emergency and why we should really learn on past crisis. And then we will work on what we call the 4 pillars of the response in major epidemics that should be on board, which would be managing the emergency, the medical challenge, communication as a critical element of the response, and of course the logistical support to crisis, and it will go to some conclusions. So over the past year, the COVID Observatory, where you can find the link here, we have been producing series of notes on COVID on education, which were very much in line with what the President Speaker just said. COVID on social cohesion and social tension, COVID on migration, COVID on food security and economic security, COVID on disaster, etc. They're all present in French and English on our website, so you can access them. This one was this note I'm presenting is a concluding note. So in that approach, we identify again the importance of being ready for health epidemics and health emergency. I was just hearing a research paper this morning on the risk coming from the Amazonian forest, which is being so degraded, new problems of zoonosis and animal/human possible contamination. There are a lot of discussions on the new viruses that can be released with the warming changes in the climate in Siberia, with the melting of the permafrost, which might release new viruses. So many more viruses that are threat, including the fact that the movement of animals, the movement of humans, the movement of goods is being now so large that there would be probably new pandemic and new large-scale epidemics in the pipeline. So we have to be really ready. What we find as critical is, in fact, and we saw that clear and large in France and in many other countries, most of the accent, most of the attention has been given to the medical part of the treatment, of the management of the health crisis. And of course, this is understanding because it was seen as a health crisis. In fact, it's much larger than that. It affects all components of societies, human relations, economic, survival, movement of people, culture, etc. So the trying to approach the COVID crisis through only a medical approach turned out to be largely wrong in many countries, including my own. What lessons learned from the past crisis, health crisis, is that management of a large-scale health crisis has to be based on 4 pillars: emergency pillar, health and medicine pillar, logistic pillar, and communication. On the health, we know there are 2 key priorities. One is having a credible early warning system. And in fact, that was a big challenge with this one. We know that the first warning came early January in Wuhan, and there have been a lot of worries whether it was serious, not serious, a lot of difficulties. WHO tried to do its best with the alert, worldwide alert in the end of January, but in many countries the alert was not heard. So many countries did not manage it properly. So this is something that has to be taken on board. Establishing credible early warning system is a must-have for in front of possible crisis health. The second priority, which was not always well understood, is that in those type of situations, priority should be protecting the health workers. This was one of the lessons learned from the Spanish flu in 1919, so more than a century ago. that health workers are both critical players of the response, but also they can be critical agent for the contamination. So managing them, protecting them is critical. And for those of you who might have worked in Ebola or cholera lately, we know how important it is to get the health worker well protected, otherwise they die as well. And this happened a lot in the COVID. The third key lesson is that in a health crisis like that has to be taken on board through multidimensional response. It is both a water, a food security, economic. If you want to have containment, you have to organize the logistic of it. So it requires specific skills, which are the global crisis management skills. And this is very important. And it was not seen that much as a priority in many contexts. Then it means you have to mobilize emergency response specialists, not only medical specialists. You have to have a fire brigade, you have to have civil defense on board, sometimes even the army, volunteer networks that are well trained for disaster management. They should be all part of the response, not only the medical doctors and the nurses, because otherwise you miss that critical element of the multidisciplinary element of the crisis. Then we can go to one which is absolutely critical in the with the what we call the crisis managers. Crisis managers, they know one thing: you should just not remain responsive. You have to be proactive. You have to always try to be one step, two steps ahead of the developing crisis. Medical systems are much less reactive, even if they can develop models and projections. They are not necessarily in the mood of proactive action, and this turned out to be a problem in many cases. Of course, the second element is the medical challenge, and we all know, and many of you are part of that. It's absolutely essential. Strengthening the capacity of health system to manage emergency is critical. It starts by something very difficult, which is support triage. We know how triage can be a difficult task for medical staff, and of course for the families of those who are not taken on board. But this is critical, and these people have to be prepared. Sites have to be organized for triage. I just come back from Lebanon, where to support the management of the crisis over there. And of course, triage in the hospital was seen as one element. Managing the clear separation between contaminated area and the non-contaminated area, this is in hospital is absolutely essential if you don't want to have contamination spreading all over the medical structures. Another element is, and it has not been taken on board properly in many cases, is the management of corpse handling and funerals. In fact, what we know is bad management of corpse of deceased and bad management of funeral can leave a long-lasting psychological impact on families and society. So this is something very important. And we know that sometimes corpses themselves can be actors of contamination. So very important to manage that properly. Then, of course, discharging patients who have been treated and who seems to be getting out of the disease is a complicated area, because for a long time we didn't know whether those discharged patients would not be hidden super contaminators. So that was something very important. And this links to the whole issue of public health protection measures, quarantine, lockdown, which was often seen as a constraint. And they were constrained, but sometimes we have to work on them properly. And this will lead to probably one of the most important, well, yeah, of course, vaccination. I mean, when I went last time in Ebola zones in January 2020, I got vaccinated, and I was very happy to be vaccinated, because during all my other missions in Ebola zones in 2014, 15, and 16, I was not vaccinated because there was no vaccine, and I was, I should say, quite concerned. But now we have this vaccination. It became a big fight among countries, among companies, and I think WHO is doing its best to get that international agreement on sharing vaccines with developing and underdeveloped countries. This is a big struggle, but we know this is the only way out of those big elements. Now we go to something which is often forgotten. It was definitely forgotten in France, but in many other countries, communication is critical. We know that if you want to influence public, if you want to ensure that respect of proper measures, you have to have a good protection, a good communication strategy. And this has been missing very frequently. I was very happy to hear what our colleague in Hong Kong just organized, but I think this is sometimes absolutely critical. And to do that properly, you just don't need to have communicators. You have to have social science specialists. People can understand how society see health crisis, health risk, death, sorrow, because you can build your messages through this understanding of what social science can tell us on perceptions. This was not often done properly. Then logistics. Managing health, managing products, managing vaccines, managing lockdown areas, and ensuring the proper access to food for those who are locked down. All those things are logistical issues. And too often, logistics was seen as a kind of, it's like the dirty job of moving bodies or moving medicines or moving food, while this was absolutely critical and often largely left aside as a secondary issue. In fact, logistics in managing a large-scale health crisis is absolutely essential. And so, in terms of conclusion, I think we have to be ready always, and we have always to be ahead of time. This means that we have to invest much more in understanding the rising risks of new viruses. We have to work much more on getting those 4 pillars working together through training sessions, through scenario planning, to have the logistics, the crisis managers, the medical doctors, and the communication actors working together is absolutely critical. These were issues that were raised in our report in March 2020, and it has been largely left aside. We have been having a new note in February, March 2021 to remind how important those things are for the players. And of course, at the end of the day, these were the fact that some of those lessons have been forgotten resulted into a lot of deaths, but also to long-lasting psychological impact for the worldwide population. And I think this could have been partly avoided if the lesson learned from past health crises would have been taken on board faster, more rapidly. It's interesting, of course, if we compare countries in Asia, where there is much more experience after the SARS, the MERS, things were largely managed better than in many of the rich countries that thought that the health system was so good that they would be able to manage the crisis properly. In fact, they did not. Neither Europe nor the US managed those things properly. So I think lessons learned from the past are critical. We saw African countries moving very fast to the communication approach on public health, community approach on messaging, and this was largely forgotten in many other countries, especially European countries. So I think we have to learn a lot. In fact, but more than that, we have to make sure that the lessons that have been extracted from crisis in the past are properly used and not simply put in the shelf. And I will stop here. Sorry, my PowerPoint disappeared in my computer crash, and you can access all the notes that we produce in the COVID. I will just do a quick link to our COVID observatory. Is it here? Yes. So I will just put you on a new doc. Share screen. Where is the share screen? Yes. Do you still hear me?
Yes, we can hear you clearly.
So now I am putting the link. I am putting the link to the. I don't know if you see it. To our COVID observatory. Is it appearing in your screen?
No, not yet.
Okay, I don't know what's happening. Or maybe. Oh. Huh.
Still, you're not pressing on the share screen.
Sorry? Yeah, I will put it on the share screen. Let me just try again. Last attempt. Okay. Is it coming? Okay, so it doesn't seem to be coming. I will put it on the share share screen. It's very strange. Do you see it? Oh yes, you get it. It's coming.
Yes, I can see it.
So okay, this is a COVID observatory, and you can find that we did several things that could be of interest for some of you. We organized a large-scale after action review September last year, and then if we start back, so we started by the study we did, in fact, 10 years ago on all kind of risk, including health crisis and pandemic. So in 2010, we produced a report on mapping future unintended risk, where there is a lot of things on possible coming pandemic. Then we did that review I mentioned earlier on lesson learned from the different risks. And then you have 13 different notes that you can download, which are there and available. So this is our contribution to our collective work. Thank you. And the link, I don't know if you see the link. Do you see it? No.
Yes, we can see it.
Okay. So that's the end of my presentation. So I'm most happy to respond to questions.
Okay, thank you so much. It was really honored to have you, and it was really informative. So does anyone have any question? Please feel free to ask. It seems that there's no questions, but please, if you have any question, just leave it in the chat box, okay?
Okay.
Thank you. Okay, thank you so much. So now we will go back to Jakub to have his second presentation. You're so welcome to start.
Okay, I am ready. I want to share my screen.
Yeah. Before you start, Yaqub, Francis, we have Dr. Talha. He is asking for your email.
Yes, so I will put it on the discussion.
Okay, thank you. Okay, go ahead, Yaqub. You can start.
Okay. Yaqub Matai from Kerala, India. Today I want to discuss with you subject is fever is not symptom in COVID-19. None of the disease require a fever as its a symptom. We have been hearing for centuries that fever is not a disease but a symptom. Physicians say that fever is a symptom of disease like flu or cancer. Conservative fever definition, diagnosis, and treatments are based on fever as a symptom. All the studies related to fever as a symptom of a disease have been done without knowing the purpose or temperature of fever is. In the current COVID epidemic situation, it has great importance because fever is considered as a symptom of COVID-19. Not knowing the purpose or temperature of fever, how can fever include as a symptom in COVID-19? In COVID-19, up to 80% of patients have no fever. Why up to 80% of patients with the COVID-19 virus have no fever? Is it because there is no need for the care of fever, or is it because disease is free of symptoms? Most of the disease may not have fever. Sometimes it disappears. Then is fever a symptom of which disease? Is the temperature between 38 to 41 degrees centigrade can be symptom of a which disease? What is the use of symptom definition? As any or all other definitions, symptom definition should be describe symptom scientifically. If it cannot describe it clearly, there is no use of a symptom definition. Symptom definition is the only parameter necessary for a symptom. Symptom definition. A symptom is a departure from normal function or feeling, which is noticed only by a patient, indicating the presence of disease or abnormality. A symptom is subjective, observed by the patient, and cannot be measured directly, whereas the sign is objectively observable. A symptom can more simply be defined as any feature which is noticed by the patient. A sign is noticed by other people. Not even a single trace of symptom definition can be seen in fever definition, and vice versa. The symptom definition, fever definition cannot be found. In symptom definition, fever definition cannot be found. The elevation of body temperature is not included in symptom definition. The main evidence which proves that fever is not a symptom of the disease is symptom definition itself. A symptom has no ability to make other actions. During fever, sponging with the water is used to reduce temperature. Then shivering takes place to produce heat. Shivering is a heat-producing action. The shivering due to decrease of temperature in fever never comes under the definition of symptom. An action can never become a symptom. Is elevated temperature a scientific criteria or parameter of symptom? No. The patient cannot feel elevated body temperature. According to symptom definition, fever is not a symptom. Then what are the criteria to assess a symptom? Nobody knows. Then on which scientific basis can fever be considered as a symptom? Nobody knows. If elevation of body temperature is not a symptom, then what? One cannot be understood directly if the temperature is elevated in the hypothalamus. A mechanical device is necessary to measure elevated temperature in the hypothalamus. According to sign definition, it is a sign. Then arises another question about body temperature. If elevation of body temperature is a sign, then in which category will temperature of fever come under? Signal category, like a traffic signal. Everybody can feel, no device is required. In the beginning stage of fever, the patient and others cannot feel the rise in temperature. Elevated temperature or increased temperature never make fever or symptoms of fever. Different cause of disease never shows same symptoms. Different cause of disease like virus, bacteria, fungi, venom, Paracetin and paratrin, etc. never shows the same symptoms. Its actions are different and sometimes opposite. No similarities can be seen between their actions. All the symptoms, signals, and of hypothermia can be seen in fever too. That means there is a common basic science behind these phenomena. None of the disease or cause of disease require fever as its symptom. The symptoms of virus, bacteria, and venom are not based on fever. Patients who have flu to cancer may not have fever. The nature and strength of virus, bacteria, and venom cannot be diagnosed with fever. At the same time, nature and strength of virus, bacteria, and venom can diagnose by its symptoms and signals. The symptoms, signs, signals of fever are only seen at the presence of fever. During cancer, the symptom, signs, signals of cancer are shown every time. A patient having cancer and fever at the same time, symptom, signs, signals of both cancer and fever are shown every time. A symptom of cancer never becomes a symptom of fever, or symptom of fever can never become a symptom of cancer. If fever is a symptom, one symptom has no ability to make other symptoms. If fever is a symptom, we cannot call a person as a fever patient. If fever is a symptom, no treatment is required to reduce fever. Treatment is required only for disease and its cause. Our immune system never increased, elevated the symptom, the hypothalamus. A symptom can never cause pattern. There is a sharp difference between symptoms of fever and symptoms of rising temperatures. Symptoms of fever include body pain, bitter taste, fatigue to maintain body, reduced appetite, reduced motion and indigestion, an aversion towards cold substance, internal external discomfort, etc. If symptoms of fever are mentioned above, how can fever be a symptom? That is the question. Symptoms of rising temperature include likeness towards cold items, like to drink cold water, feel discomfort while using a blanket, feeling hot, etc. If the symptoms of rising temperature are mentioned above, how can rising in temperature be a symptom? That's another question. According to there is no similarities between symptoms of fever and symptoms of rising temperatures. Fever never shows symptoms of rising temperature like decreased body pain, like cold substances, heat to hot substances, feel discomfort while using a blanket. We can prepare a table showing symptoms, signs, signals, and actions of disease, fever, and rising temperature. This table is known as Jacob's table showing symptoms, signs, signals, and actions of disease, fever, and rising temperature. Left side of the table, you can see symptoms of fever. Middle of the table, symptoms of rising temperature. The right side of the table, symptoms of disease. Below that, signals of fever, signals of rising temperature, and signals of disease. Below that, signs and actions of fever, signs and actions of rising temperature, signs and actions of disease. How can we separate symptoms of disease and symptoms of fever and symptoms of rising temperatures? A fever condition means symptoms, signs, signals, and actions of the disease and fever are included. If we deduct disease from fever condition, we will get fever. So we can prepare an equation from fever condition. Fever condition minus disease equal to fever. Like that, we can separate signs, signals, and actions of both the fever and disease. This is the table. Jacob's equation of separating fever, hypothermia, symptom, signals, signs, and actions from fever condition and hyperthermia condition. Left side of the table, you can see fever condition. Right side of the table, you can see hyperthermia condition. Symptoms of fever, both the symptoms of disease and symptoms of fever are included. If you deduct the symptoms of disease from total symptoms of fever condition, we will get symptoms of fever. So we can prepare equation symptoms in fever condition minus symptoms of disease equal to symptoms of fever. Signals in fever condition, both the signals of disease and signals of fever are included. So we can prepare equation signals in fever condition minus signals of disease equal to signals of fever. Next, signs in fever condition, both the signs of disease and the signs of fever are included. So we can prepare an equation signs in fever condition minus signs of disease equal to signs of fever. Next, actions in fever condition, both actions of disease and actions of fever are included. So we can prepare equation actions in fever condition minus actions of disease equal to actions of fever. A hypothermia condition means symptoms, signs, signals, and actions of both disease and hypothermia are included. We can separate symptoms, signs, signals, and actions of both hypothermia and disease. If we deduct disease from hypothermia condition, we will get hypothermia. So we can prepare an equation hyperthermia condition minus disease equal to hyperthermia. This is the equation. Symptoms of hypothermia condition minus symptoms of disease equal to symptoms of hypothermia. Signs in hypothermia condition minus, signals in hypothermia condition minus signals of disease and equal to signals of hypothermia. Next, signs in hyperthermia condition minus signs of disease equal to signs of hypothermia. Actions in hypothermia condition minus actions of disease equal to actions of hypothermia. In fever does not show any actions of temperature rise. A new fever definition, diagnosis and treatment is required, already narrated in former presentation. How can we prove fever is not a symptom in COVID-19? Fever is not a symptom in COVID-19 when examined in various directions. We can separate symptoms of fever and symptoms of disease and symptoms of rising temperature. Like that, we can separate signs, signals, and actions of fever and disease and rising temperature. If we ask any type of question related to fever by assuming that the fever is not a symptom of COVID-19, we will get a clear answer. If we avoid or evade from this, we will never get a proper answer to even a single question. If we do any type of treatment by assuming that fever is not a symptom, the body will upset at the same time, body will resist auto treatment to decrease blood suppression, besides that we use a symptom efficient. No further evidence is required to prove fever is not a symptom. The benefit of the timing fever temperature as a signal. The purpose of the definition of signal is to analyze the signal scientifically, to differentiate it and also to brief it and understand it easily. If we say there exists temperature as a signal, one can easily understand without much explanation. In such a situation, automatically comes apt word as well as apt definition. That is why it is told to exclude the temperature of fever from symptoms of the disease. Conclusion. The fever is not a symptom of COVID-19 when examined in various directions. Temperature between 38 degree and 41 degree cannot be a symptom of any of the disease. None of the disease or cause of disease require fever as its symptom. A different cause of disease like virus, bacteria, fungi, venom, horror scene and horror dream never show same symptoms. Opposite disease never shows same symptoms. Fever has never been scientifically proved as a symptom of a disease. Fever has the properties of adaptation. Fever treatment should be revised according to the onset of disease. A new fever definition, diagnosis, and treatment is required. It is wonderful that a physician having years of experience in fever treatment cannot understand actual fever definition and fever treatment have no relation with symptom prevention and diagnosis. In the early days of my discovery, I thought that fever is a symptom of disease. I never got any answers for even a single question about the symptoms that induced me to find out the real truth of fever. I can eliminate conservative fever definition, diagnosis, and treatment. If you discard this discovery, it would be an injustice to mankind. Thank you. Hear me patiently so far. If I want to share my email address. This paper is also published in a journal also. The link also, I want to share the link of the paper. Hello.
Okay, thank you so much. Yakub, thank you so much. It was really great presentation. Everyone got the most benefit of it too. Does anyone have any questions? Please feel free to ask. We are welcoming any questions.
Okay, you can ask. Now I want to, if you have I am not fit so fit now. I am suffering from cold and fever. So I will share my email address and other details. You can ask any questions after some time. I am unable to answer now because my health is very, very poor.
Okay, hope you get really better soon.
Okay.
Okay, so now let's start with the next speaker. Okay. Dr. Shaima Pada, Professor, Department of Zoology, University of Gorbanja, India, is interested on infectious disease, probiotic and genomic and bioinformatics research. He did pre-PhD, PhD, and post-PhD research under the guidance of Professor Nishit Kumar Pal at Bankura School of Tropical Medicine, India. He has published 115 articles with 8 books chapters. He is life member of IAMM and IASR India and fellow member of SASS India. 8 national academic and research awards have been confirmed to him. He has guided 52 postgraduate students, supervised 3 MPhil and 3 PhD students, and supervising 6 PhD students. Professor Mandel is among the world's top 2% scientists as per the survey of the Stanford University published in PLOS, Public Library of Science, Biology, October 2020. We are so happy to have you, Professor, and we can orderly ask you to start.
Yes, can you hear me, ma'am?
Yeah, we can hear you.
Hello?
Yes, we can hear you
Can I share
clearly.
my presentation?
Yeah.
Okay. Please allow me to share. Hello?
Yes, Professor.
Please allow me to share, ma'am. Host
Okay.
disabled attendance screen sharing. Please allow me.
Okay, I will just ask my team now to put you as a co-host.
So I cannot share my slide.
Okay, just 1 minute.
Yes.
Now you can share your screen. Can you see option share screen?
No,
Not
it is
yet.
not allowed. Please allow me. On which video, my video is showing that laptop, not mobile. It is written host disabled attendance screen sharing.
Make the screen share.
Yes, but you have not allowed me. This has been disabled. It is not possible to share. On my screen, host disabled attendance screen sharing.
Just a second, doctor. Is it now available? I just made you.
Yes. Yes, it is available.
Yeah, now we can start.
Can I see my screen?
Yes, we can see your screen.
Okay, thank you. My slide is opening, PPT. Hello, sir and ma'am. Good afternoon and good afternoon to all audience. Can you hear me, please?
Yes,
I
I
am
can
Professor
hear you.
Samapada Mandal. I am going to present my, yes, thank you, ma'am. I am going to present my paper, which is entitled Molecular Docking and Admit Studies to Explore the Antiviral Efficacy of Terminalia cebula bioactive compounds against SARS-CoV-2 druggable targets. Presenting Shamapada Mondal. So, you know, we are in a pandemic and this is in a worst situation. Therefore, we have to take some measures because we are not going to our institute for academic research in wet lab system. So we are working in our host in silico system. So the scope of the study is molecular docking of Terminella cebula, which is a plant, is a medicinal plant. It has many bioactive phytochemicals. So we have we have utilized some phytochemicals from Terminella cebula plant and prepared ligand. Protein were obtained from PDB system. Molecular docking was done. 3D and 2D presentation were analyzed, and we have seen the Lipinski rule, rule of 5 for the ligands to be used as drug, and their bioavailability radar were prepared to test their bioavailability and admit. That means absorption, distribution, metabolism, excretion, and toxicity were tested. So, what is the background of this study? I have already told that we are in a pandemic. SARS-CoV-2 is the virus that caused COVID-19 pandemic, and this is very devastating because more than 1 year it is occurring, and the situation is like this. The 150 million crossed the case number and 2.9 million death occurs, and vaccination is occurring. And this is the situation in United States, which is top in the world in the case number, then India, and then Brazil. And we are seeing that the total case number is like this: 31 million here, 14 million, and 13 million in Brazil. And new cases highest in 2.23 million in India. This is highest in number, and the death is like this. 1,341, and in Brazil the highest number of death is seen, 3,560. So the case is very devastating, and we have seen that still there is no approved drugs are available for the treatment of COVID-19, and the repurposing of the drug are occurring, and there is no effective vaccine also, though there is some answer about vaccine. It is under processing, and that's why we have selected some phytochemicals from Terminella cebula plant, and we utilize this RDP, RNA-dependent RNA polymerase, 3CL-Pro, M-Pro, and this S protein of the virus. These are 4 viral targets besides methyl transferase of the viral part, and another is helicase. These enzymes are utilized. Here we are seeing some drugs which are given against some targets such as RDRP, 3CL-Pro, PL-Pro, and H2. There are some other targets also, and red in color, these are the drugs. These are acting against such targets. So you are seeing that these are not suitable because such drugs are found unsuitable, not in every cases. And we are seeing that plant contains some phytochemicals. These are bioactive phytochemicals which can act against helicase. These are viral enzymes, and inhibitor are myricetin, sclerotrin, and caffeic acid amidine. This can inhibit the angiotensin converting enzyme. This is a target of human, and another human target, TMPRSS2. Lutein is very effective against this target, and another target, PL-Pro from virus part. There are some phytochemicals such as sorafenib. This is very important to inhibit the PL-Pro activity, and some inhibitors are also found, which such as herbacetin, amantoflavone, roifloin, and these are inhibitors of the 3CL-Pro. And we have selected some phytochemicals, some Terminella cebula, and before that, the study utilized some software because we have done the work in silico system, molecular docking, and ADMET profiling. This is UCF Chimera version 1.5. We have utilized this system, this software, in PyMol Open Bubble version 3.1.1, BioVia Discovery Studio 2021, PKSM web server, and Swiss ADME. This is for ADMET analysis and RO5 analysis RCSB PDB, from where we have obtained the viral targets, that means protein structures, and from PubChem we have retrieved the phytocomponents. These are actually chabulic acid, this is chabulic acid, this is ellagic acid, and this is quercetin. These three components we have retrieved from PubChem, and their idea are represented in green color. And there are some enzymes we have retrieved already, say potent data bank, and this is 3CL Pro, this is helicase, and this is methyl transferase. And we are seeing that we have prepared the pockets from a pocket 101 P program. This is a program for pocket identification in protein structure. These are viral structures. So we are seeing that we have utilized 3 phytochemicals. Here red color or magenta color, this is chabulic acid, yellow, this is ellagic acid, and green, this is quercetin. And we are seeing that in the pocket after docking, these components, these phytochemicals are occupied in the same pocket here, in the same pocket, but in different two positions. And here this is only one is seen, and this is the chabulic acid. And so we have retrieved these three, and another three also we will show in the next slide. And these are the PL Pro, this is RD, RP, and this is S protein, and they are docked. After docking, the phytochemicals are found to inhibit the virus, taking the same position in the pocket. Here all this is yellow color, this is red color, and this is green color. Here all the three ligands are occupied within the pocket of the enzymes which are retrieved from PDB. These are the protein of SARS-CoV-2 virus, and we have performed molecular docking using UCSF Chimera version 1.15 already I have told, and for that we have prepared dimension 50 into 40 into 44 into 40 Armstrong for all the 6 proteins. And these PDB idea of the proteins are for S2 6LXT, RDRP 6M71, MT 6W61, helicase 6ZSL, PL Pro 6W9C, and 3CL Pro 6WTZ. And we have prepared centers for different center for different enzymes of SARS-CoV-2. That means 6 enzymes: PL Pro, 3CL Pro, helicase, methyl transferase, RNA-dependent RNA polymerase, and S2 subunit of spike protein. These are the center for docking. And after docking, we have seen that we have obtained 18 complexes. That means for 6 enzymes against which 3 phytochemicals are inhibited. And this is very first one, 3CL Pro and chabulic acid. Here we are seeing 3D and 2D presentation. We are showing in green color the hydrogen bond, and these are the amino acid, and this is the ligand. And for that, a very good interaction was achieved. This is a very good inhibitor. And here we are seeing that a large number of green color showing that hydrogen bonds are formed, and the closest bond is 2.12 Armstrong, and the bond angle is 137. That means this is a very strong bond. Also, 2-dit hydrogen bond, pi sulfur bond, and pi T shapes are visible. And another 3CL Pro ellagic acid, this is in another inhibitor to 3CL Pro. This is 3D presentation, and this is 2D presentation. We are seeing that the binding energy of this association is minus 7.3 kilocalorie per mole. And we are seeing that, like the chabulic acid, ellagic also from different types of bonds, and the closest to the ligand is the amino acid and glutamic acid, and this is 1.62 Armstrong in distance, and the bond length is more than 130 degree, that is 146 here. And pi sulfur bond and pi T shaped are also formed to strengthen the bond or the association. Here quercetin, similar kinds of association are achieved, and the binding energy is somehow lower. That means the stronger the association is, lower the binding energy. So this is the association here. At least 10 pi bond is available in addition to pi sulfur and hydrogen bond to strengthen the association. And here another helicase. This is another enzyme of virus against which chavulic acid presentation is showing here, and the high binding affinity is seen for chavulic acid also to helicase, and binding energy is minus 7.3, and the closest it was glycine, and 0.13 Armstrong distant, and bond angle is 33. And this is helicase, and the bond 3 and 2 representation, and relatively this elagic acid was very effective helicase because low energy, that means minus 0.1 mole is required. And here elagic acid against helicase, we are seeing that amino acid is arginine 551 and the bond length 131, and more into the hydrogen bond, pi carbon bond as well as pi stacks are visible, and this quercetin, the third phytochemical against helicase, and binding energy also high, minus 7.78, and we are seeing that this is the amino acid 2.04, and this is the closest one, and the bond angle is 152 degree. And here chavulic acid and methyl transferase, this is the different types of bonds, and elagic acid methyl transferase, and the closest one is aspartic acid 1.86, and the bond length is very near to 180 degree. That means this is a very strong bond 166, and in addition to the hydrogen bond, another kind of a pi anion, pi sigma are also visible, and this is quercetin against methyl transferase, and the closest bond length is 2.3 Armstrong, and the bond angle is 145.4 degree, and these are 9 number of pi T-shaped association were found in this complex. And PL-Pro, this is third one, chavulic acid acted on it and inhibited the viral PL-Pro, and this is the strongest one, the bond, hydrogen bond 1.86, and the angle is 155 degree. And this is the elagic acid against PL-Pro, and binding energy is very high, binding affinity is very high, and binding energy required is very low, that minus 8.3. And here we are seeing that pi T stacked as well as pi sigma bonds are found, and the closest one is 2.01 for asparagine, and the bond length is like this, and the angle is 133. And this is quercetin against PL-Pro. These are hydrogen bond, other 6 at least 6 in number of pi stacks are found, and 1.95 distance. This is the closest one, that means glutamine, and the bond length is 132. And this is chavulic acid for another RNA dependent RNA polymerase. Here closest amino acid was lysine 391, and bond angle was 170 degree. And this is elagic acid against RDRP. We are seeing that this also binding energy also low, minus 7.0. And we are seeing that different kinds of bond are found, the 6 in number, pi sigma, and bond length 151. And this is quercetin against RDRP, and this is different types of bonds, and you are seeing the pi sigma bonds number of R6 in addition to the hydrogen bond, and bond length like this 136. And this is chavulic acid against the last one, enzyme. So we are seeing that the closest amino acid was serine, the bond distance was 1.98, and bond length was 141. Hello, can you share me? Okay. This is elagic acid against H2, and these are the association, and binding energy required for the association was a minus 7.7 kilocalorie per mole, and the asparagine was involved in the very effectively with bond angle 146 degree, and the bond distance was 2.13. And this is quercetin against S protein, and the bonds of different types are shown in this table. And here ADMET analysis, so we have performed Lipinski rule in ADME and PK. We have utilized Swiss ADME and PKCSM tools to analyze the toxicity, administration, and drug-like property. We are seeing that this is chebulic acid, and we are seeing that the polarity is beyond the limit. This is the pink region. So except the polarity, the chebulic acid shows all the characteristics that are acceptable, that means lie within the pink zone. This is the bioavailability radar, and bioavailability score is very low for chebulic acid, 0.1, and this is for ellagic acid, bioavailability score is 0.5. This is very high. Still, their in saturation is extended beyond the pink zone. Here, the similar situation for quercetin, the bioavailability score is 0.55. In saturation is beyond the pink zone. So, and this is boiled egg analysis, W log P, and this is topological polar surface area. When we have plot and the graph, we are seeing that our all three molecules, that means within this square, molecule 1, that means chebulic acid, 2 ellagic acid, and 3, this is quercetin. We are seeing that the intestinal absorption rate is very high for molecule 2 and molecule 3, that means ellagic acid and quercetin, but not this is very low, and no substances, no compounds are found to enter into the circulate into the brain, and no components are found to P glycophosphate enzyme inhibitor or substrate. And we are seeing that Lipinski rule, that means we are seeing that for chebulic acid, here H bond acceptor is more than 10, that is 11, and bond donor is more than 5, that means original number, the required number is less than 10 or 10, and here 5 or less than 5. So except this point, all the other two, that means ellagic acid and quercetin, obeyed the rule of Lipinski rule of 5. So they are these ellagic acid and quercetin are possessing characters that are drug-like characters. And so ADMET profile, we are seeing that their absorption distributions are fine. Water solubility was high, and skin permeability is also high. In log S, that means this is water solubility is high. So, and we are seeing that they cannot permeable to the brain and central nervous system also. So we are seeing the metabolism. No one, that means among the three phytochemicals from Chebula plant, no one inhibitor of this enzyme system or cannot be the substrate of this enzyme. Excretion rate is like the tolerance level, as well as these are not substrate of OC2. And toxicity, we are seeing that M test, all the three compounds are against M test, that means not toxic to M test. And we are seeing that hepatotoxicity no for all, and skin sensitization is no for all three components utilized in the docking process. So the findings to the highlights of the finding, that means in conclusion, chebulic acid, ellagic acid, and quercetin showed inhibitory activity against 3CL-Pro, PL-Pro, helicase, methyl transferase, RDRP, and S5 protein S2 subunit of SARS-CoV-2. Molecular docking authenticated the SARS-CoV-2 target protein inhibition by chebulic acid, ellagic acid, and quercetin. Stable protein ligand complex formation was due to the high binding affinities of the ligands to the target proteins of the virus, that means binding energy is less than or equal to minus 6.5. We have got all the phytocomponents that show less than this kilocalorie per ml required energy in their association. And ADMET profile signify the therapeutic stability and suitability of the phytochemicals quercetin and ellagic acid, except the chebulic acid against COVID-19 treatment. And these are the publication in the field of COVID-19. This is the publication. And lastly, I acknowledge Public Health Webinar 2021 Organizing Committee, United Research Forum, for the recognition of my research and supporting me for this presentation. Thank you. Stay safe, stay healthy. Thank you, ma'am.
Thank you so much. It was really a great presentation. I hope everyone also enjoyed it because it was really informative. Thank you so much.
Thank
Wondering
you.
if anyone have any question? You can leave it in the chat box, please. It seems that there is no question, but if we get any, I will just I'll tell you, okay? And thank you so much. It was really big honor
Yes,
to have you.
you can send question. Thank
You are welcome. Now let's welcome the next speaker. Okay, now we're gonna welcome Professor Tahani Ali Salem. Tahani Ali Salem completed her PhD in pulmonology nursing at Alexandria University, Egypt. She is a clinical instructor at Medical Surgical Nursing Department, Faculty of Nursing, Alexandria University, Egypt since 2007. She is a member of pulmonology rehabilitation team at Chest Disease Department at Main University Hospital, Alexandria University, Egypt since 2014. She is Associate Professor at Nursing Department, Applied Medical Science Faculty at Al-Baha University, KSA, since 2020. You are so welcome, Professor Tahani, to start your presentation.
Hello, do you hear me?
Yes, Professor Tahani, we can hear you.
Okay. Just 1 minute to share my presentation.
Okay.
Okay, hello everybody. First of all, my special thanks and sincere appreciation for all participants and attendees, and special thanks for organizer committee to organize this EE conference. Today, I will present a very interesting topic. I hope to be a very interesting topic about post-COVID-19 infection pulmonary rehabilitation. As we know, COVID-19 disease or COVID-19 became a pandemic since March 2020. Today we will provide hope and enlighten the road for infected people with COVID-19 through engagement and implementation of pulmonary rehabilitation, which because pulmonary rehabilitation alleviate symptoms post-COVID infection, such as dyspnea or shortness of breath and easy fatigability. Improve exercise tolerance. Do you hear me? Hello, do you hear me? Hello? Hello?
Yes, we can hear you.
Okay. Pulmonary rehabilitation can improve exercise tolerance through endurance or resistance exercises, and improve health status and the health-related quality of life. Let's start our objectives or outline. We will talk about recent statistics about COVID-19, pulmonary rehabilitation definition, PR's benefits, PR's different program settings, PR's indications, PR's components, PR program at home, pulmonary rehabilitation at home, and finally improvement of clinical indicators or clinical parameters after pulmonary rehabilitation. This slide shows a recent statistics in 20 February 2021. The coronavirus or confirmed cases about 1 million, about 1 million, 111 million cases, and confirmed deaths about 2 million and 2.5 million deaths in 20 February. But in 20 or 18 April, yesterday, positive or confirmed coronavirus cases about 140 million cases, and confirmed deaths about 3 million cases. This after two slides, the conclusion can conclude that there is an increase in the coronavirus cases due to many factors or many causes in all over the world, and this pandemic, we observe the changes all over the world, or in negative impacts and the economic burdens all over the world and all over the sectors, especially economy, education, and especially health sectors. According to American Thoracic Society, pulmonary rehabilitation is a multidisciplinary program of care for patients with chronic respiratory impairment that is individually tailored and designed to optimize each patient's physical and social performance and autonomy. The program is tailored according to patient's needs and according to every patient's needs. Benefits of pulmonary rehabilitation. Pulmonary rehabilitation has many benefits, like or such as improved exercise capacity, reduced breathlessness or shortness of breath, improved survival, reduced the hospitalization and the exacerbation, reduced anxiety and depression, improved the health-related quality of life, improved the psychological well-being. According many studies, there are some studies focused on the importance and the engagement of pulmonary rehabilitation. According to Brazilian Journal of Physical Therapy, there is a research paper about recovery after COVID-19, the potential role of pulmonary rehabilitation. This is the focus or the importance of pulmonary rehabilitation. Another study was conducted or developed at China, pulmonary rehabilitation for patients with coronavirus disease, 2019. Pulmonary rehabilitation can be conducted or held in many settings, especially an inpatient department, an outpatient department, and the home-based rehabilitation. Home-based rehabilitations, and nowadays, tele-rehabilitation is recommended for infected people with COVID-19 because we need to limit access to healthcare agencies or hospitals to minimize the spread of infection. Goals of pulmonary rehabilitation. Pulmonary rehabilitation can alleviate the symptoms, especially easy fatigability and shortness of breath, increase the exercise capacity, increase the activity of daily living, improve the quality of life, improve the behavior, especially anxiety and depression, which are associated with COVID-19. Decision making, make the patient or make a client to take his or her own decision without influencing factors, give empowerment and self-determination, and so on. Who is eligible for pulmonary rehabilitation? Pulmonary rehabilitation is indicated for chronic respiratory diseases or chronic respiratory conditions like chronic obstructive pulmonary disease, bronchial asthma, chronic bronchitis, cystic fibrosis, sarcoidosis, before and after chest or lung surgery. The pulmonary rehabilitation team include referring provider physician, nurse practitioner, respiratory therapist, registered nurse, physical therapist, occupational therapist, medical director, exercise physiologist, supporting staff, dietitian, way nutritionist, social workers, way psychologists, and pharmacists. This is an interdisciplinary team. The components of pulmonary rehabilitation. The pulmonary rehabilitation consists of four main domains: education, exercise training, nutrition, and psychological status. First domain, education, includes patient initial assessment, medical history, assess client or patient condition, respiratory history, active medical problems, surgical or medical history, family history of respiratory diseases, either bronchial asthma or chronic obstructive pulmonary disease, especially genetic type, alpha-1 antitrypsin deficiency, use of medical resources, current medications, either prescribed or over-the-counter medication, allergies, drug intolerance, smoking history, occupational environmental exposures, alcohol and other substance abuse history. Education includes also educational material and devices, patient literature and books, lung model, medication devices like nebulizer device or machine, like inhalers, either meter dose or dry powder inhaler, oxygen delivery devices, especially for patients with long-term oxygen therapy, airway clearance devices such as chest physiotherapy, Borg scale or MMRC, Modified Medical Research Council scale, and quality of life measurement tool. This scales Borg or MMRC to assess the shortness of breath or dyspnea, and depression scale, intimacy handout, relaxation exercises. This is one of the important item about education is the self-management of symptoms or self-management education, prevention of exacerbation. Exacerbation, the term exacerbations means deterioration of the symptoms or worsening of the symptoms beyond the usual. Breathing strategies, bronchial hygiene methods, medications, symptom management, especially shortness of breath, self-assessment, exercise training and benefits, activity of daily living, and energy conservation. The second domain, exercise training. Exercise training, it includes endurance and resistance exercise. The program or the rehabilitation program includes exercise type and 5 stages. It includes 5 stages or phases of exercise. It started with a warming up stage and ended with a cool down stage. There are 5 stages. A modality for a warm up stage, global range of motion exercises, breathing control, stretching exercises. For aerobic, walking, cycling, and stepping, resistance training, free weights, ankle weights, and elastic bands, major muscle groups of upper and lower limbs and trunks. Balance training, upright positions, adjustment of the center of gravity in static and dynamic postures, with dual cognitive and motor tasks. And the final stage of exercise, a cooling down stage or cooling down phase, includes breathing control, stretching exercise, and relaxation. The time of program rehabilitation, the time lasts from 45 to 60 minutes, 3 days per week, and the type of exercise, as we mentioned before, warm up and stretching exercise, endurance training, aerobic exercise, which means aerobic exercise, and muscle strengthening, muscle strengthening or muscle resistance exercise. For exercise training, pulmonary rehabilitation, general exercise training include upper limb endurance training, upper limb strengthening training, while lower limb endurance training, lower limb strengthening training, flexibility and stretching exercise, balancing exercise. Usually it takes from 4 to 10 weeks, 3 days per week, while lower limb training improves exercise tolerance through no effect on measured lung function. Upper limb training improves arm strength and reduces ventilatory demand. There are examples of upper limb strength exercise such as shoulder press, biceps curl, wall press. These all exercises for strength upper arm or upper muscles and respiratory muscle to decrease ventilatory demand. Lower limb strength exercise such as knee extension in sitting to strengthen calf muscle. Squat exercise to improve quadriceps and hamstring muscles. Climbing stairs or use stepping hooks. These the 3 main types of lower limb strengthening or resistance exercise. Another type of exercises should be added in the pulmonary rehabilitation program, which is breathing exercise. Breathing exercise or pursed lip exercise, special type pursed lip breathing exercise. Pursed lip breathing exercise technique through inhalation deeply and slowly from the nose and exhalation through a pursed lip. This maneuver or this procedure or this technique improve or prolongation of the expiratory time, and this is lead to wash of the CO2 or retained CO2. Pursed lip breathing exercise is very important, especially for chronic respiratory disorders. The third domain or the third element, nutritional assessment through anthropometric measurements like height and weight, body mass index, weight changes and calculate body mass index from weight and height, weight changes, dietary eating patterns, suitable food preparation, fluid intake, alcohol consumption, need for nutritional supplements. This is nutritional assessment. The last domain and the fourth domain is psychological assessment. I think this is a very important item. This is the very important domain in the 4 domains because the patient, the first refused to engage in the pulmonary rehabilitation because the program painful program and need physical well-being and need physical mobility, and patient with chronic respiratory disorder have limited physical mobility, and so there is a difficulty in engaging the pulmonary rehabilitation. So perception of quality of life and ability to adjust, it's a very important item to assess. Interpersonal conflict and anxiety and depression, substance abuse, addictive disorders, neuropsychological impairment, sexual dysfunction, motivation for pulmonary rehabilitation. Another study showed the impact of pulmonary rehabilitation in the sleep in the COPD patients measured by actigraphy. There is a difference between actigraphy and polysomnography. Polysomnography, it is actigraphy. It is a non-invasive method, a non-invasive technique to assess the rest and the activity periods for a client or patient. But polysomnography is the standard measure for the standard of the gold standard for measurement of sleep. And this study, this table, shows the effect of pulmonary rehabilitation on COPD, respiratory, sleep, and neurocognitive variables. After implementing pulmonary rehabilitation for COVID-19 patients or for chronic respiratory disorders, chronic respiratory conditions like chronic COPD, chronic obstructive pulmonary disease, this table showed that there was a statistical significant difference and improvement in St. George Respiratory Questionnaire, this questionnaire to assess the quality of life. This is improvement, and there was a statistical significant difference and improvement in respiratory questionnaire, St. George Respiratory Questionnaires. In addition, a COPD assessment test, which called CAT scale, اللي هو chronic obstructive pulmonary assessment test, and a modified medical research council scale to assess dyspnea, and finally, finally 6-minute distance walking test. There are therefore parameters or clinical or physiological indicators which are considered as a prognostic index for chronic respiratory condition, St. George Respiratory Questionnaire to assess quality of life, CAT scale, COPD assessment test to assess the quality of life for COPD, modified medical research council scale to assess dyspnea, and a 6-minute distance walking test to assess the level of activity for these patients or COVID-19 or COPD patients. At the end, we conclude that the importance of pulmonary rehabilitation and the engagement of telerehabilitation now is recommended for infected people with COVID-19 because we need to limit access to healthcare agencies to minimize the spread of the infection. Thanks for listening, and if any questions, I'm ready. Thank you. Hello?
Thank you, Doctor. Yes, I can hear you, and it was really great presentation. Thank you so much. Thank you for the great offer that was put in this presentation. And we have a question for you from Dr. Talha. He's asking, which exercise has the best outcome with regards to post-COVID patients? Can you hear me, Doctor?
Question? No. Repeat again.
Which exercise has the best outcome with regards to post-COVID patient?
Okay. There are two types of exercise. Either for range of motion exercise, a simple exercise, just movements of joints through range of motion exercise. Okay. And the other type of exercise is strength exercise or resistance exercise, which focus on muscle resistance and muscle strength. Muscle strength, we need upper and lower patient with chronic with COVID-19 complain of shortness of breath or dyspnea, and this is a very disturbing or a very annoying symptom for a patient. And lower exercise, upper limb and lower exercise, especially resistance exercise to strengthen arm muscles and lower limb muscles. Some studies found that these exercises improve dyspnea and improve shortness of breath and decrease an interval between an attack of dyspnea and the subsequent one. Hello?
Okay, thank you so much for your response.
Okay.
And Dr. Talha is thanking you too for the answer. Any other question? Okay, it seems that there's no other questions. If there is any question, I will let you know, okay?
Okay.
Thank you so much.
Thank you.
Now, welcoming the next speaker. I will just share the paragraph here.
Okay, I will go. Okay.
Okay, thank you. Now going to the next speaker, Professor Yue Hu. Professor was trained in epidemiology and public health. His research interests lie in epidemiology and chronic diseases, healthy aging, and the risk factors using longitudinal data from large cohort studies. After she obtained her PhD from University College London, she worked as a research scientist at the Max Planck Institute for Demographic Research. Currently, she works at Chongqing Medical University as an associated professor. So we are really happy to have you, Professor, and you're so welcome to start your presentation.
Thank you. And I'm going to share my screen.
Yeah, you can share your screen.
Okay. Sorry. So first of all, I'd like to, I'm really grateful for the opportunity to present our study of the effective control of SARS-CoV-2 transmission in Wanzhou, China. And this is a teamwork. Could everyone hear me?
Yes, we can hear you.
Okay, perfect. And this is a teamwork, and this work has been published already Nature Medicine. And if any of you want to read the paper in more details, please just go to the website and download the full paper. So first, I would like to share about the geography location of Wanzhou. So as we all know that Wuhan city is the epicenter of the COVID-19 outbreak in China. And Wanzhou is actually located in the Chongqing municipality and to the west side of Hubei province. And the distance between Wuhan and Wanzhou is not it's not that far, actually, in the sense of the in the sense of how big the China is. It's the distance is about 500 kilometers. So at the beginning of the outbreak, Chongqing was a project to be the one of the next cities that will be heavily hit by the COVID outbreak originated in Wuhan. Since we sort of evaluated the effectiveness of the control measures of COVID-19 in Wanzhou, I'd like to give some background of what the control measures were. So first, the Chongqing municipality initiated the first level response to the major public health emergency on the January 24th, 2020, the next day after Wuhan city was locked down. And the local CDCs were required to complete the epidemiological investigation of confirmed COVID-19 cases by RT-PCR within 24 hours. This also includes tracking down the close contacts. So the close contacts were identified through interviewing the identified cases, their family members or doctors who treat the cases. And the identified close contacts, they were required to report relevant information on their contacts with the case. For example, when they had the close contact with the case, how long the contact lasted, the frequency of their contacts with the case, the place and the mode of contact, as well as the relationship to the case. This figure gives you a more sense of the timeline of the management of COVID-19 cases and close contacts in Wanzhou. So as I said before, the Wuhan city was locked down on the January 23rd, and on the 24th, the next day, Chongqing initiated the first level response to the major public health emergencies. And after that, the cases, all the identified cases, they were transferred to the designated hospitals immediately. But for the identified close contacts, they were transferred to the hospitals for further test and treatment if they reported having or having had symptoms. If they didn't report any symptoms, they were required to be quarantined at home. However, this practice changed after the changes of the protocol for COVID-19 prevention and control by China National Health Commission, which was revised on the February the 6th. And since February the 8th, Wanzhou adopted the changes. And one of the big changes that all the previously home quarantined close contacts, the close contacts identified between the January 24th and February 8th, they were required to be tested by RT-PCR. And since February 8th, the close contacts who didn't report any symptoms when they were identified, they were required to be quarantined at a centralized location and tested by RT-PCR. So for the case, after the case being discharged from the hospital, they were also required to quarantine for 2 weeks, either at home, which was the practice before February the 8th, or at the centralized locations, which was the practice on and after the February 8th. And after 2 and 4 weeks being, after they were discharged from the hospital, they were required to go to the designated hospital for follow-up checks at the second and the 4 weeks after the discharge. So in our study, we use the data that were extracted from the Wanzhou CDC, which basically included 2 parts. So one part was the epidemiological investigation reports of all positive cases tested by RT-PCR between January 21st and April 10th, 2020. Why the reports started from January 21st? Because that's the date when we found the first COVID-19 case in Wanzhou. And actually in late March and April, there were no longer new cases in Wanzhou anymore, except the imported cases from other countries. The second part of the data was the contact tracing records of all identified close contacts. So we included 3 types of individuals in our study. First is the symptomatic cases who were RT-PCR positive and didn't show the symptoms either before presenting to a hospital or during the 2-week quarantine period as a close contact during their hospital stay, or within 4 weeks after being discharged from the hospital. So this definition for the symptomatic is quite strict, actually, compared to many other studies. And for the asymptomatic cases, they were cases who reported no symptoms throughout this period, which was again was quite a strict definition for asymptomatic as well. So the close contacts, as detailed in the protocol by China National Health Committee included those who lived, studied, or worked together with the source case, the health care staff who provided care to the case, the family members, relatives, and others who took care or visited the case in the hospital. And they also include the patients who shared the same hospital ward with the case, people who took the same transport as the case, and others who met the criteria for close contact after evaluation by the investigator. What we did that set our study apart from others is that we identified the transmission clusters with multiple generations. So the transmission clusters were sorted out by identifying the source case, and the generations of transmission within each cluster were based on the date of first contact with the source case. So this is the example of the cluster of the SARS-CoV-2 transmission with 5 generations. This cluster actually originated from 2 cases, the A1 cases and the A2 cases, and we could see from the legend that the different color in the box represents different severeness of the case, and the dashed lined box represents the asthmatic cases. So we can see that the A1 and so the A2 case only infected only infected the 1 person in the next generation, the generation B, and for A1, actually A1 and A2 they are a couple. So that's why we couldn't really separate them. But A1, we could see that A1 infected the generation B, and the generation the case in generation B, they further for this case B1.1, for example, this person infected 3 asthmatic case in the generation C, and 1 symptomatic in generation C as well. And the case in the generation C, the C1.1.1, this person infected 1 and 2 asthmatic cases, and 3 asymptomatic cases and 3 symptomatic cases. And it's interesting that for the case that D1.1.13, this person actually infected 5 asthmatic cases. So that's so because we have the clusters of transmission with multiple generations, which allowed us to calculate the characteristics of transmission with more detailed data. So in our data, in total we have 183 cases, and among the 183 cases, 123 of them were symptomatic, and 60 of them were asymptomatic. And the generation 1, the G1 case, were the cases who traveled from Wuhan or its neighboring area to Wanzhou. So they were actually the imported case in some sense. So we have 30 symptomatic and 9 asthmatic G1 cases, and these 39 cases, they had close contact with 692 individuals. And among these 692 individuals, close contacts actually, 54 of them were infected and symptomatic, and 20 of them were infected and asymptomatic. So in total of 74 G2 cases, they had close contact with 660 individuals, and among them, 13 were infected and symptomatic, 16 were infected and asthmatic. And these 29 G3 cases, they had close contacts with 142 individuals, and among them, 9 were infected and being the G4 case. And these 9 G4 cases had close contact with 163 individuals, and 5 of them were infected, and all of them were asthmatic cases. And none of so these 5 asthmatic G5 cases, they had close contact with 8 individuals, and none of the 8 individuals were infected, and the transmission ended. This is another figure that we did to show you how the SARS-CoV-2 transmitted in Wanzhou. So each color represent one generation of the case, and so as we can see that so the January 23rd was a time when Wuhan city was locked down. And these gray vertical lines represent the date when they had their contact with their source case. So basically we could think that this is this approximates the time that they were infected. As we can see that so most of the close contacts for the cases in Wanzhou actually happened before the lockdown of Wuhan city, and there were only few, quite not that many close contacts that happened after the lockdown of Wuhan city. And as we could see that for these solid lines represent the symptomatic cases, and this small black dots represent when they had their symptom onset. As we could see that actually the timing of symptom onset actually varies pretty significantly between the symptomatic cases. So we and for the data analysis, we calculated the post median of incubation period. Of course, because it's the incubation period, we could only calculate it among the symptomatic cases. It's the date of the first contact with the source case minus it's a time difference between the date of the first contact with the source case and the date of symptom onset. And we calculated using the Bayesian approach with the Weibo distribution, which was in line with the study from Barker and others. We also calculated something we called the transmission risk period for the asthmatic cases, which we defined it as the time difference between the date of the first contact with the source case and the date of the diagnosis, which was the date that they were confirmed positive by RT-PCR. So this is the result for the posterior median of incubation period and the transmission risk period. I don't want to say too much about the posterior median of the incubation period for the G1 case, because we actually don't know when the G1 cases had their first contact with their source case. But basically, for the G2 and the G3 cases, the posterior median of the incubation period were between 10 to 12 days, which was significantly longer than the 7 days that was reported previously. And for the asthmatic cases, the transmission risk period were between 20 to 32 days, which means that actually they were the symptomatic cases were out there in the community for quite some time before they were identified. We also calculated the reproductive number just using its definition. And we calculated the 95% confidence interval using the bootstrapping. So as we could see that the G1 to G2 reproductive number, it's 1.64, which was not as large as the basic productive number, because when the G1 transfer the when the G1 case is transmitted the virus to the G2 cases, there were already some sort of control measure. So so that's why it's lower than the basic reproductive number. But with more restrict control measures being implemented, we could see that the reproductive number for the G1 to G3 transmission and for the G3 to G4 transmission decreased very quickly to 0.3 and 0.4, which means that the control measure were very effective once they were started to be implemented. This figure actually shows the what we call the distribution of the offspring per case. This distribution actually shows how dispersed the ability that the case could transfer to others. And we can see that actually the G1 symptomatic cases, their distribution of the offspring were more overspread, which means that which means that there could be, if any overspreading event happened, it would only happen among the G1 symptomatic cases. And because for the asymptomatic cases, most of them actually didn't transmit the virus to others. We also calculated, because we have the data on the multi generations for each cluster, so we could calculate something that we defined as the timing of contact, which is that the time difference between the contact A and the contact B. The contact A is the time when the source case had contact with their source case in the prior generation, and the contact B was the time when the close contact had contact with their source case. So in other words, the timing of contact, what we were trying to capture is that after how many days the source case was infected, the close contact had contact with the source case. We also evaluated the risk factors for the SARS-CoV-2 transmission using the multi-level logistical regression, and we found that actually the risk of being infected were not associated with gender or age, but it was associated with the timing of contact, that if the close contact I'm sorry, someone is sharing the screen. Okay. I will just continue. Is that okay?
Yes, please continue.
Shall I just continue?
Yes, please continue.
Okay. So so basically we found that the timing of contacts within 5 days, which means that if you had contact with your source case within 5 days after your source case being infected, and if you have a long contact of your with the case for 8 hours or longer, and frequent contact will significantly increase your risk of being infected. So as we could see that I talked about this figure before, that that actually in Guangzhou the control measure was gradually being more strict over time, especially for the close contact who were home quarantined at the beginning and then being quarantined in the centralized location and being tested by RT-PCR multiple times during the quarantine. So this figure actually we use this figure to sort of argue the effectiveness of the control measure. So what we could say is that so after the initiation of the first level response to the major public health emergencies in Chongqing on the 24th of January, the number of close contacts happened afterwards decreased very dramatically, as well as the contacts by dining together also decreased very quickly. Because so when the outbreak occurred in China, it was a time of the Chinese New Year, and for the traditionally people would dine out a lot. That's why the dining together was one of the indicators to show how people actually were social distancing. Of course, we also simulated the predicted number of cases in Guangzhou if there were no control measure at all. We use the epidemic spreading on complex network model. And as we could see that, so actually because the y-axis is on the exponential scale, so actually the actual difference is even much bigger than what you see on this picture. So according to our simulation, the peak daily new cases would happen on the January 31st around here, for the with about 400 new cases on that day, and the total case in Guangzhou will reach 560,000, and actually in the reality we only have 183 cases, which also shows how effective the control measure were. So in conclusion, the spread of COVID-19 was effectively controlled in Guangzhou via social distancing, including face mask wearing, thorough contact tracing, mass testing, identification, and early diagnosis of pre-symptomatic and asymptomatic cases, and strict quarantine of close contact. And targeting the main risk factors, including the timing, the frequency, and duration of contact will be the key interventions for mitigating COVID-19 and for better handling of possible resurgence in the future. And that's all. Thank you.
Thank you very much for your wonderful presentation, Dr. Yao. Does anyone have any questions regarding this presentation? Okay, fine. It seems nobody is asking any questions. And thank you very much for your presentation, ma'am. And I would like to introduce our next speaker, Hema Rosaline. Can you hear me, Dr. Hema Rosaline?
Hello, good afternoon. Yes, I can hear you.
Just a minute, ma'am. I'll introduce you and then you can give presentation, okay?
Excuse me.
Yes.
I have a technical problem in sharing my screen. First of all, I'd like to apologize. When the previous presenter was presenting, it was an error. I'm very sorry. My sincere apologies related to it. But I'm having a technical issue in sharing my screen. Would you mind if I present it after the next presentation?
Sure, sure. Just give me a second. Let me check if the next presenter is able to give presentation. Dr. Al-Hassan.
Yes, I'll do the next one, please. I'm sorry.
Yes. Dr. Al-Hassan.
Thank you very much.
Can you give presentation? Dr. Al-Hassan.
Hi.
Hi, Dr. Al-Hassan. Can you give presentation now?
Yes.
Okay, I'm just making you a co-host so that you can give a presentation.
Yes, okay.
Let me introduce you now. 1 second.
Oh. Hello, can you hear me?
Yes, ma'am. Yes, I can hear you.
Yes. Repeat.
Just a second, ma'am. I'm going to introduce you. Hello, everyone. Our next presenter is Dr. Al-Hassan Said Khali, and she is from Fayoum University, Egypt. Okay. And Al-Hassan Said Khali is an associate professor of community health nursing, faculty of nursing from Fayoum University. Please, ma'am, continue your presentation.
I can begin, okay?
Yes. Let's start.
Hi. I talk about immunization education program for mothers needs to children under 5 years regarding immunization in rural area. Aim of the study. This aim to evaluate education program for mothers needs to children under 5 years regarding immunization in rural area. Design, quasi-experimental research design was used. Sample, purpose of sample equal 70 mothers who having children with age under 5 years attending the routine immunization. Setting, study was conducted at maternal child health centers at Sanouris District, El Fayoum City, rural area, Egypt. Definition of immunization. Immunization is the process of artificially including immunity or providing protections from disease. Active immunization is the process of stimulating the body to produce antibodies and other immune responses through administration of a vaccine or toxin. Passive immunization, provision of temporary immunity by administration or performing antibody derived from human or animals. Type of vaccine. Live vaccine, inactivated or killed vaccine, subunit vaccine, toxoid and protein vaccine, recombinant protein vaccine, polysaccharide-based vaccine, conjugated vaccine combination. Why do we vaccinate? Stop the spread of disease, build community immunity, protect people too sick to vaccinate, protect people too young or too old to vaccinate. Protect those not fully immunized, those who do not get full protection from vaccination. Strengthen the body natural immunity. 3 ways to support immunization in your child care program. Check immunization record regularly to ensure each child in your care is up to date on their vaccination. Educate yourself and ensure that you and and your staff are vaccination. Educate parents in your program and help connect them to credible resource. Immunization schedule. Recommended immunization help protect infants and your children from. You hear me?
Yes, we can hear you. Go ahead, please.
And young children for 14 diseases: chickenpox, diphtheria, flu, hepatitis A and B, hib, measles, mumps, pneumococcal, polio, rotavirus, rubella, tetanus, whooping cough. Educate yourself and your staff. Educate yourself and any staff about the childhood immunization schedule, the benefits and risk of vaccination, vaccine preventable disease. Key message to tell parents: look into your state child care vaccination requirements. Vaccines are the best way to protect infant and children from 14 serious disease. Vaccines protect their children and they also protect other children. Immunize Egypt resources. Egypt State Immunization Program resources, County Health District, Community Health Nurse. What are the clinical advantage of vaccinating and early recommended age? Children are protected earlier from vaccine preventable disease that can spread rapidly in a children setting. Vaccinate children help protect unvaccinated or under-vaccinated children, staff, and other persons in the child setting. Frequency distribution of the mother total knowledge pre-post educational program regarding general knowledge about immunization, number of women as 20. Shows that there was marked improvement in mother total knowledge regarding general immunization post-implementation of education program with highly statistical significant difference, where good knowledge was 75.7%, better than 28.6% at pre-program where p-value 0.00. Frequency disturbance of the mother total reported practice regarding immunization shows that 69.8% of mothers, there was a marked improvement in mother total practice about immunization after implementation of education program with highly statistical significant difference, a p-value 0.00 between pre and post test after implementation of educational program. Risk of delaying immunization. Barrier to health care access can also cause immunization delays, but delaying some vaccine in addition to leaving children unprotected from disease longer can actually increase the risk of fever-related seizures. Delaying the shot is not without a risk most serious infection from pneumococcal disease. Are in the children less than 2 years, so the idea to protect children as soon as we can delay just means they remain unprotected from longer period of time. What happens if child misses vaccine? When children are not vaccinated, they are at risk of getting disease like measles, polio, and hepatitis A and B. That can cause lifelong disability or death. Failing vaccination rate can lead to new outbreaks of dangerous disease. Immunization keeps children healthy so that they can spend more time learning, growing, and socializing with peers. It's important for child care programs and child care provider to make immunization a priority and foster an environment of health through child care policies, education of staff, and parent education. There are many ways that you can educate parents using resources from CDC, state and local agency, and credible organization. Immunization. The study donates that there was improvement of mothers' knowledge and reported practice at post-education program than pre-education program with statistically significant difference. Provide mothers pay health education and immunization booklets, which include the importance of immunization, side effect, and how to manage it, obligatory vaccine schedules and non-obligatory vaccine schedule in MCH center. It takes a village to protect our children, families, and the community against vaccine preventable disease. Thank you. Any questions?
Thank you very much for your presentation, Dr. Al-Hassan. Does anyone have any questions about this presentation? Yes, if anyone have any questions, you can always post it in the chat box. And thank you very much, ma'am. And I would like to introduce our next speaker, Rosalind.
Thank you. Thank you.
Ma'am, can you hear me? Dr. Rosalind?
Yes, I can hear you. Can you hear me?
Yes, ma'am. And I just made you co-host, and just give me a second. I'll introduce and you can start your presentation.
Sure, sir.
Hello, I would like to introduce Dr. Hema Samson. Dr. Hema Samson is working as lecturer at Sultan Qaboos University of Oman. She has completed her bachelor's from Government College of Nursing and master's from St. John's National Academy of Health Sciences, Rajiv Gandhi University of Health Science. She has worked besides as registered nurse, technical officer for the WHO Founder Research Projects and coordinator for GFATM project. She has clinical teaching experience in the surgical, intensive care, and emergency units. Her area of interest in research is related to non-pharmacological interventions for pain management. Please, ma'am, you can continue your presentation.
Good day to you all, because we are from different time zones. Are you all able to hear me?
Yes, ma'am, we can hear you.
Okay. So from this part of the country where I am, it is almost 3:30 in the afternoon. Yeah, I hope you all can see my screen. Is it visible? Hello? 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 Hello?
Yes, we can hear you.
Can you see the slides that I am showing?
Yeah, we can see your desktop.
No, I'm actually projecting a PowerPoint slide. Is that visible?
Yes, ma'am. This is visible.
Thank you. Thank you. Well, the pandemic is not new to us. It's been here for around a year now, and we can't call it a celebration for sure. It's here, and in more ways than one. Either one of us have been directly affected, or some of our loved ones, or somebody whom we know. I would like to highlight the effects of electronic cigarettes and COVID. According to the WHO report of 2020, almost 8 million lives are lost annually due to the use of tobacco. Direct tobacco use contributes to more than 7 million deaths, and 1.2 million are due to non-smokers being exposed to secondhand smoke. The tobacco industry has floated about $1.4 billion marketing campaign to instigate youngsters to adopt the noxious habit that kills millions every year. Now, this report of COVID figures are as of about 2 hours ago. The figures show about 144 million who were reported positive for COVID, and almost 3 million have succumbed sadly, and about 120 million have recovered. Okay, what are e-cigarettes? E-cigarettes are also known as electronic nicotine delivery system, and it is also referred to as vaping devices. And people who use these are referred to as vapors. It was basically invented by a Chinese pharmacist way back in 2003. So it looks more like those of us who are in the medical field would know the insulin syringes. So it looks more like a pen, more like a pen. So it is a rechargeable electronic device that is battery operated and emits vaporized nicotine to inhale. It comprises of a cartridge attached to a tube containing liquid solution, an atomizer that heats the liquid to form vapor, a sensor that triggers the atomizer when the user sucks the device, and the e-solution or the e-liquid that incorporates a combination of nicotine diluted in propylene glycol solution and a flavoring agent. Now, sadly, these flavoring agents come in very lucrative aromas. We get mint and vanilla and various other aromas which are very lucrative to users especially. So what is the truth about e-cigarettes? It is being lauded as a safer substitute to conventional tobacco. It is sadly being recommended by healthcare workers as an impressive, competent method to aid in quit smoking. Incidentally, there is a steady decrease in the estimated number of smokers globally and a rapid increase in the number of vapors. The primary reason behind this is because healthcare workers are recommending vaping as a substitute to quit smoking, which is not the truth. So nicotine, which is derived from tobacco or Nicotiana tabacum, is a component of e-cigarettes. Consumption of nicotine in any form has protracted ramification on one's health. The pharmacokinetic property of nicotine confers to its addictiveness. A passive exposure of e-cigarette emission for 30 minutes results in immediate alterations of small airway and exhaled biomarkers reflected by increased resonant frequency and reduced fractional exhaled nitric oxide during an impulse oscillometry was seen. Studies which have been published in the SAGE Open Medical Case Reports and Lancet has revealed that lung injuries caused by COVID-19 and its manifestations are very, very similar to those caused by e-cigarettes. Nevertheless, there are contradicting studies as well, which shows that there is no influence of smoking on the lungs. Well, I beg to differ on this. I don't know if it is politically driven. Well, so how does this virus spread? We are all aware of it, but what about cigarette smoking? Cigarette smoke is known to travel to a distance of about 1.5 meters, which is approximately 5 feet. And social distancing is asked, the distance that we are asked to maintain in social distancing related to the pandemic is around 6 feet. But in the most populated countries of the world, being China and India, I wonder how practical this is, at least in the cities and towns. Most smokers, if we see, begin to smoke out of sheer inquisitiveness or social obligations, peer pressure, or arduous boredom. Sadly, vaping is taken on by children from high school. Majority of the statistics show that children get addicted to vaping or try vaping as young as high school kids. So a person with COVID-19, as all of us would be aware, can become contagious 24 hours, 48 hours before starting to experience symptoms. Vaping is generally, as I told, indulged among the youngsters and is being recommended even amongst the older people where they are addicted to the regular or the traditional smoking. So, and vaping is also indulged in groups, and hence the likelihood of spreading COVID during vaping is amplified. And here is a picture of the effect of smoke or smoking and coronavirus on the alveoli, which is the functional unit of the lungs. In both of these, we can see that eventually the alveoli is the one which gets affected, and the primary function of it being air exchange is being altered with fibrosis which takes place and alveolar destruction and mucus hypersecretion as in case of smoking. And the changes are kind of similar even in case of the coronavirus. And an example that I often give is fibrosis, which was given to by my teacher, is like when you're chewing gum. Initially, when gum is being chewed, it is not just sweet, but it's also elastic. But over a period of time, it becomes hard, which doesn't allow us to blow a bubble. So that gives me a good understanding of what can happen during fibrosis, and hence air exchange being altered results in respiratory failure and eventually a patient succumbing to coronavirus. Where is vaping banned or restricted? I hope my screen is visible. It just shows it's restricted in countries like Australia, Canada, Hong Kong, India, Norway, and Japan, though I'll tell you about India and Japan further on. And it's strictly banned in the Southern American countries like Argentina, Brazil, yes, and other countries like Brunei, Cambodia, Colombia, Egypt, Indonesia, Jordan, Lebanon, Malaysia, and Panama, Mexico, Philippines, Qatar, Singapore, and so on. But the sad thing is, even though it is banned in some of these countries and it is restricted in some of these countries, there are ironically laws which are being prevalent in these places. So some of the laws which are seen is if you look at the UK, because smoking has created a costly burden for the postal services, the country stands to save money if smokers switch to e-cigarettes instead. And in the United States, you would see that the FDA has authority over vapor products, but they have literally spent about the last 8 years trying to create a working regulatory system. The reason behind this is that the government gains or earns a lot of tax through these products, be it tobacco or alcohol. Canada has somewhat followed the UK model, but as in the US, its provinces are free to make their own rules that sometimes conflicts with the goals of the federal government. Prohibition is most common in the Asian countries and South America. And as I mentioned earlier, in Japan, vaping is legal and the products are sold except e-liquid with nicotine, which is illegal. So I think the first or the second slide I shared about what the e-cigarette is all about. So it basically contains a certain amount of liquid, and this liquid primarily is impregnated with aromas and contains nicotine. So it is very ironical that in Japan, that it is legal to vape, but it is illegal to sell nicotine. And the most famous nicotine ban belongs to Australia, which is great. And we in the Middle East, the part where I live, we have a country which has imposed a sin tax. So sin meaning sin which is wrong or not acceptable by society, moral, low moral standards. So a sin tax is imposed in one of the countries, emphasizing and discouraging the use of tobacco products. In India, the Juvenile Justice Act of 2015 made the sale of tobacco to minors meaning children below the age of 18 years, a criminal offense, which is punishable by 7 years of rigorous imprisonment. It is one of the few countries to have a powerful deterrent that firewalls children. In conclusion, I would like to say that vaping products are often mislabeled so that users believe they're using nicotine-free products, but most likely contain nicotine. The World Health Organization estimates that by 2030, 10% of the annual deaths globally will be related to tobacco. Needless to mention, the numbers could be manifold given the global pandemic and the controversy shrouded around vaccines and the emerging variants of virus. I hope our political machinery and our community milieu and family members would reach out to support youngsters and those addicted who are wanting to quit and be freed from the bondage of nicotine. And in one way or the other, could have an impact on the spread of COVID. I understand that now in the second phase, we are having huge casualties and the scenario globally is quite disturbing. But if we could save the younger generations who are going to be the futures of the pillars of the future, I think we should reach out to them, especially the healthcare workers, and also sensitize the public about the truth behind these e-cigarettes. Thank you.
Thank you very much for your fabulous presentation, ma'am. Does anyone have any questions regarding the presentation? Okay, if anyone have any questions, you can always post it in the chat box.
Thank you. Thank you very much. I would like to thank United Research Forum for giving me an opportunity to speak about e-cigarettes. It's something that is weighing very heavy on my heart because of, especially because of the pandemic and the camouflage by the politicians and the world at large that e-cigarettes can be used as a substitute to quit from smoking. Thank you.
Thank you very much for your presentation. I would like to introduce our next speaker, Dr. Salma Hamid. Can you hear me, Dr. Salma Hamid?
Yes, I can hear you clearly.
Just a second, ma'am. I'll introduce you and you can give your presentation.
Okay.
Hello, and I would like to introduce our next speaker, Dr. Salma Hamid. She is working as PhD researcher in the Faculty of Science of Brits, Cambridge University, Tunisia. Recently, she got her PhD diploma in biological and environmental science, and she is a scientist loyal to treatment of agro-industrial wastewaters via biotechnological and microbiological process. Our research interest lies, amongst others, within the biotechnological treatment and valorization of agro-industrial wastewater into highly added value products like food, nutritials, and biochemicals, as well as our interest in nanotechnology and the biosynthesis of various nanoparticles with pharmaceutical applications. Our undergraduate backgrounds in applied biochemistry and molecular engineering can also be helpful in assessing and a biological approach in the environmental sector. Please, ma'am, you can continue your presentation.
Can you hear me now?
Yes, ma'am, we can hear you.
Is it my screen share or not?
Yes, ma'am, started.
Yes, it is it.
Yes, ma'am, it has started.
So good day to you all. First of all, I would like to thank the organizing committee to give me the opportunity to collaborate in this event and also to make the e-conference of public health and in this similar conditions. I hope everyone is all right at this moment. So my presentation is a little bit different from the other. However, I would like to outline on the impact of wastewaters, industrial wastewaters, and their efficient treatment. Over the years, agro-industrial wastewater have been one of the major contributors to world economy. They are the main of industrial pollutions. Day by day, rapid growth of population, so that is why rapidly increasing industrialization of the country. So all the industries require a huge amount of water for different industrial processes. Industries use water that obtained from water treatment systems for a variety of purposes, for manufacturing, cooling, heating, as a carrier for waste matter, as a solvent, and also as a carrier of raw material. This was resulting of water in classifying of wastewaters. What is a wastewater? Wastewater is generated a product from industrial process. We need for operation having constitutes which can cause harmful and hazardous effects to human, animal, plants, aquatic and microbial lives, and different forms on the earth. It is toxic and hazardous to the environment. As we can see here, the wastewater are discharged in the rivers, in natures without an appropriate treatment. And there are alternatives for disposal of industrial wastewaters. As I said before, without any treatment and disposal in municipal, we can discharge it in a municipal sublet for combined treatment and separate treatment of industrial waste before they disposal into receiving water land. They are characterized by various contaminant pollutants like suspended solid, colloidal solid, inorganic and organic salts, organic compounds like pesticides, insecticides, oil and grease, ammonia, phosphates, heavy metals, and also we can have in their pollutants microorganisms like viruses, bacteria, and a lot of them. This effluent and this wastewater have a hazardous impact on the environment by containing toxic and hazardous materials, as I said before, from the waste that is disturbed in the river in the bottom and is settled in the bottom as a sediment and constitute a health hazard to the urban population that depend on the water as source of supply for domestic uses. Impact of industrial effluents have environment is not limited to water bodies alone, rather cut across all portions of the environment. Impact of industrial effluents would be discussed as it affects each compound on the environment, namely, like on soil by reducing porosity, affecting aggregate stability, and affecting the soil enzymatic activity. Also in water by affecting eutrophication of biotic and abiotic, also affecting the groundwater quality. And also in plants by inhibition the seed germination and increasing the dry yield matter. It's characterized by usually different from industry to industry, like olive oil industry, fish industry, or maybe oil industry, textile industry, and many other industries. They vary from process to process in the same industry. They have either too high a proportion of suspended solids, dissolved inorganic and organic solids, biological oxygen demand, and variety of pH also, and have a variety of temperature and composition. Generally, the objective of this wastewater and the industries is to try to find a way to treat this wastewater by a treatment to protecting public health and the environment, by also protecting surface and groundwater resources from pollution, and also improvement the aesthetic quality of the environment. You can hear me? Hello?
Yes, ma'am, we can hear you.
Okay.
Yes.
Thank you. Okay. As we can see here, the life cycle assessment of this wastewater was originally developed to obtain a cleaner product of industrial product, is to obtain the huge industry use a huge amount of water to their processes, though in this besides we have a generation of a huge amount of wastewater. So the originality is to develop a cleaner production, a cleaner water after this, to saving energy and resources, less emission of harmful substance, and promoting recycle and use. These processes have analysis of environmental performance of product from cradle to grave. We can see that from for students, the treatment from this discharging to be treated to be healthy and cleaner to the environment and the public health. If minimizing of environmental impact is one of the main functions of wastewater treatment system, then they should be designed so that their total impact on the environment is reduced. This is the life cycle assessment. As we can see here, several treatments have been adopted to the treatment of these wastewaters, like centrifugation, membranes, and solar. It is different from physical to physicochemical processes. And we can see here a difference of COD and chemical oxygen demand removal to be healthy. We can see here a total removal, 99% of removal of chemical oxygen demand, the organic compounds that are toxic to the environment and to public health. But the main concern of the wastewater treatment is the resolution of high organic or high gases, toxic gases like methane dioxide and nitrogen, and many of them that are causing global warming, ozonation depletion, also acidification, eutrophication, and also phytochemical smoke. For that, many industries have been adopted wastewater plants that are consisting of several stages. The first one is a preliminary process, then a secondary process is a biological process, then a disinfection to have a discharged, a very cleaner water to be reused in the nature and the environment. A primary treatment, what is it? It is consisting of following unit: by removing floating matter, grid chamber for removing sand, and removing the oil, using sedimentation and coagulation flocculation. The secondary treatment is removal using biodegradable organic material. It's using microorganisms to remove the BOD, that, like I said before, the biodegradable organic matter, and suspending solid, which consists by activating sludge, like using lagoons and trickle filters. Lagoons are open flow through basins specially designed and constructed to treat biodegradable and destroyed wastewater. They provide a long detention period extending from a few to several days, which oxygen can provide through mechanical aeration rather than algal photosynthesis. Here we can see that the disposal of wastewater in a lagoon, an open lagoon to air, and the permission of microorganisms to degrade and remove the COD and the chemical oxygen demand, to remove organic materials, and to produce cleaner water. And also the secondary process of the treatment is the activated sludge process that is containing organic matter, is aerated in an aeration basin in which microorganism metabolism the suspended and soluble organic matter. It offers efficient removal of biological oxygen demand and chemical oxygen demand, and also nutrients like nitrogen and phosphorus when designed professionally and operated properly. The process itself has flexibility and numerous modifications can be tolerated to meet specific requirements, like consortium of having combining of multiple microorganisms, healthy microorganisms. I'm talking not about pathogenic microorganisms that's used here to biodegrade and to remove the chemical oxygen demand. The third process in the secondary treatment is the trickling filter, also known as percolating filter or scraping filter. Here we can see a bed of different biopolymers or bioplastics that are fixing microorganisms. And here in the pumping, in the blue ones, we can see the spreading of the wastewater into this bioplastic that contains immobilizing microorganisms that will be handling the degradation of the biological oxygen demand and the organic matter in the wastewater, then the discharge at the final step, the cleaner water that will be discharged. It will prevent the clogging of by the filter settled solid. A trickle filter or biofilter consists of a basin or tower fillet with support media such as stone, plastic, and shape. As I said before, the bioplastics, like we use bioplastic or biopolymers. Then we can have, after the primary and the secondary, we can have the tertiary treatment, this remove of nitrogen through the nitrification process by using chlorination, ozonation, evaporation is the final steps to disinfection of the water so they can be discharged without harmful. The using microbial population for bioremediation process that can be isolating from almost any environmental conditions. As I said before, the secondary treatment, they're using microorganisms that can be isolated from almost any environmental conditions. Microbes can adapt and grow at optimal temperature, aeration, and pH. The main requirements are carbon and salts, which can be used to degrade or remediate environmental hazards. Since numerous types of pollutant are to be encountered in wastewater, different types of microorganisms are likely to be required for effective remediation. It's essential to distinguish the type of microorganisms present as well as the organic pollutants to be removed. It is vital to develop more understanding of microbial communities and their response to natural environment and pollutants. Further, also nanotechnology that deals with objects on the order of nanometers finds its application in wastewater treatment and valorization. Our recent have been published in Chemistry and Biodiversity, that is valorizate wastewater from olive oil industry by synthesized nanoparticles that are effective against antibacterial and antimicrobial pathogens, human pathogens, which can be used as a drug for drug delivery, which are green synthesis and valorization of the wastewater. Which is a double valorization. Here we can see these nanoparticles here that are clearly in the side of nanometers that are synthesized greener using wastewater to having a microbial activity. Further, also, related works have assessed wastewater as the world facing the third coronavirus causing pandemics, and in this recent year, the SARS coronavirus not only affected the human respiratory system but also affect the wastewaters. Research found that where wastewater can contain coronavirus, and to prevent this pandemic, virus removal requires a technique from wastewater need to be implemented to prevent the virus dissemination into the environment. In that context, we should improve all the field of wastewater treatment from now to maybe 15 years to use algae or nanomaterials with particle emphasis on membrane-based techniques to remove and to contain wastewater viruses from wastewaters and to prevent human health, of course. As conclusion, what can biological treatment wastewater do? It's a question. It's avoiding environmental problem shifting is also a powerful tool to ensure environmental sustainability of wastewater management and can be used to optimize system design at larger scale. And what we can do here is combine different microorganisms and different process like a consortium to ensure better bioremediation and ensure that the process we select is low cost and efficient, because industries are searching for low cost management, so they not having to be requiring too much of equipment. And keep in mind that bioremediation provides a technique for cleaner up pollution by enhancing the same biodegradation processes that occur in nature. There is no doubt that bioremediation is in the process of paving way to greener pastures and worldwide safety. Thank you so much. And I wish you to be safe and stay safe and healthy.
Thank you very much for your wonderful presentation, ma'am. Does anyone have any questions regarding this presentation? If you have any questions, you can always post it in the chat box. And once again, thank you very much, ma'am. And I would
Thank you. I would like to thank you. Thank you so much.
Yes, and I would like to introduce our next speaker, Tana Mijatovic. Can you hear me, ma'am?
Yes, I can hear you. Can you see me? Can you hear me?
Yes, ma'am, I can hear you. Just give me a second, ma'am. Let me introduce you, and then you can start your presentation. Hello, everyone, and I would like to introduce our next speaker, Tana Mijatovic, and she is from Belgium. Dr. Tana Mijatovic holds PhD in molecular biology, and she has authored more than 50 publications in peer-reviewed journals, 21 as first senior author and 29 as a co-author, and holds 2 granted patents as a first author. Since 2011, she is CSO and lab manager for RED laboratories, developing and performing specialty tests to assess multifactorial dysfunctions like CFS, chronic immune dysfunctions, chronic infections, including Lyme diseases, intestinal dysfunctions, and autism, etc. Previously, she performed as head of biology in biotech companies specialized in discovery of new anti-cancer agents, publication manager and consultant of pharmaceutical companies, and scientist at University of Brussels. Please go ahead and continue your presentation.
Thank you very much for this introduction. Good afternoon, everybody. I will start sharing my screen in just a second. Okay. So I would like to share with you today yet another topic that is not a COVID related, but which deserves a lot of attention and as we are in a public health symposium, I think it is a good opportunity to share some thoughts about Lyme disease, and especially the ways of testing for it. And as you will see, the challenges for a better testing that should lead to better diagnostics and better treatment. Vector-borne infections are increasing globally, and the most known and most investigating concern borreliosis, brucellosis, babesiosis, rickettsiosis, and anaplasmosis. But many other pathogens can worsen the clinical picture and further complicate differential diagnosis. To this end, we made a large summary that is pretty much easy to understand by patients and doctors, and is available in different languages on our website. It is incredible how this little tick can make big problems if the infection is not addressed properly at the beginning. It can end up in chronic illness with serious immune dysregulation and gut dysbiosis. Tick-borne diseases, which afflict human and other animals, are caused by infectious agents that are transmitted by tick bites. We usually do not feel the tick bites because when the tick bite, it does inject kind of analgesic substance, and unlike when you compare it with mosquito, when we really feel it, we barely feel the tick bite. And that's why this event usually goes unnoticed. Thus, whenever you see the tick attached to your skin, please get it tested by PCR to see if the tick was infected. And if it was infected, then it needs to be addressed by your healthcare provider. Tick-borne illnesses are caused by infections with a variety of pathogens, and those infections are increasing globally. Lyme disease is among the most prevalent vector-borne infection in the US and Europe and is reaching epidemic levels according to the last publications. In order to raise awareness about the danger of ticks and possible infections, we prepared a tick awareness brochure that is also available in several languages. And again, since that we are in a public health symposium, it is important to raise the awareness and to join our efforts in preventing these tick-borne diseases becoming chronic. In this simple brochure, there are 4 parts. The first part is devoted to ticks, who they are, where they live, where we can get bitten by ticks, where when we are hiking, golfing, going for a walk in the wood, horse riding, etc., camping, of course. And then how to protect from potential tick bite, and how to inspect yourself when you are back from the outdoor activities. The second part of the brochure is what to do when you see the tick attached to your skin. Many patients reported they don't do how to address this, how to properly remove, how to disinfect, and what to do once they have a tick. The best thing is to get the tick tested. And after that, to monitor the symptoms over a month of period. And if anything unchanged, either skin manifestation or fever or chills appeared, just contact your healthcare provider. The next 2 parts of the brochure are dedicated to the ways of testing the ticks that have been attached, and also the ways of testing the human samples when there is a suspicion of Lyme disease or any other tick-borne diseases. As you see with this simple brochure, we can raise the awareness among those communities that are very much enjoying the outside world, the woods, the grass, etc., the outside activities. Lyme disease is the most widely known tick-borne diseases and is caused by bacteria of genus Borrelia. Because individual ticks can harbor more than one disease-causing agent, patient can be infected with more than one pathogen at the same time, thus compounding the difficulty in diagnosis and treatment. And among those neglected infections, there are, from one side, the infections that are directly transmitted by ticks, but also the others that are opportunistic and can develop over those infections. And among those neglected infections, there are tularemia, Yersinia, mycoplasmas, chlamydia, Epstein-Barr, and other herpes viruses. And our data show that prevalence of these infections are not negligible and they should be more investigated. It is important to bear in mind that tick-borne diseases can be acute or late-stage, persistent or chronic. And this is very important given that the diagnostic and treatment approaches might be different in these two situations. Lyme disease exhibits a variety of symptoms that may be confused with immune and inflammatory disorders. And if an individual has any chronic health condition, ranging from arthritis to chronic fatigue syndrome to fibromyalgia, it is really important to rule out or diagnose tick-borne diseases. It is apparent that many cases of fibromyalgia and chronic fatigue syndrome are actually tick-borne diseases in disguise. Chronic patients have complex clinical picture with multiple afflictions needing this multiple testing and careful interpretation of testing results. The overall high failure rate of therapies for vector-borne infections, and of course the absence of vaccine, especially in late persistent chronic patients, underscore the necessity to fully investigate different concurrent infections along with the resulting gastrointestinal and immune dysregulations. It is also important to investigate different co-infections, but also other opportunistic infections like viral, bacterial, and parasites. Currently used tests show several limitations. The one that is commonly used worldwide are antibody-based testing, or what we call two-tier testing. First ELISA test, and if positive, then confirmatory Western blot. This type of testing presents a lot of disadvantages. They present very low sensitivity, especially on early stage, cannot distinguish between active and non-active Borrelia presence, and there is a difficult identification of Borrelia subtypes. Typically, antibody-based tests are available only for Borrelia burgdorferi sensu-lato strains, which means that you will miss all other strains belonging to Borrelia relapsing fever group and Borrelia miyamotoi. On top of it, many patients never produce antibodies following the tick bite and following the infection, because when the tick bites, he also injects some immunocompromising and immunomodulating agents that will disrupt the connection, the crosstalk between B and T cells, and will impair the proper mounting of immune response. However, this is the most widely used test because it offers a good advantage of being pretty affordable. Another method based on bacterial DNA amplification, the PCR tests, are very interesting, but because they, of course, bring direct evidence of Borrelia presence, but they show low sensitivity and cannot distinguish between live and dead Borrelia. The third type of test that is pretty much known, lymphocyte transformation test, also provide an indirect evidence and present variable sensitivity that depends on immune system status and interfering treatments. This is especially the case for the patients who are in late and chronic stage. And of course, this test presents a difficulties of identification of different Borrelia subtypes. You have to know what you are searching for in order to get this test. There is a need for a new test development, and there was a lot of efforts worldwide. The one project in which we were involved is the one raised by Felix and Leicester University, who made a big effort in order to bring another type of testing based on uncovering the presence of specific bacteriophages. In fact, the overall high failure rate of tick-borne infection testing underscored the necessity for those novel approaches that are not relying on serology and two-tier testing. Felix phage Borrelia detection method that was patented 3 years ago consists of targeting the presence of outnumbered prophages, part of the bacterial lysogenic cycle. Bacteriophages are present only on active bacterial infections, hence a phage-based test is direct proof of an active infection. And this, as you can see, solved the problem that we encountered with previously available tests. Bacteriophages present two types of cycles within bacteria: the lysogenic cycle, when the phage infects a bacterium and inserts its DNA into the bacterial chromosome, allowing the phage DNA, now called a prophage, to be copied and passed along with the cell's own DNA. And then this lysogenic cycle can turn for a while, and for some yet not really well-known reason, the phage can enter the lytic cycle when the phage kills the bacteria and spreads in a very high number and in the host. Bacteriophages could become a diagnostic tool based on the principle that if they're phages, it is because they're living bacteria. Felix Charity, together with Leicester University Microbiology Department, have recently developed a Borrelia phage-based PCR test searching for 3 major Borrelia groups: Borrelia burgdorferi sensu-lato, and also Borrelia miyamotoi and relapsing fever group. This method is efficiently used to assess both human samples and ticks. It's highly sensitive and specific, do not generate positive signal against other bacterial strains. False positives are ruled out by confirmatory sequencing. And first publication explaining this method just appeared last month in Frontiers of Microbiology. This publication is in open access mode. If you're interested in this topic, you can easily access this data. What is the test flow? You start from biological material, usually the blood. It can be the serum, it can be the tick, it can be a biopsy, it can be urine. The biological material undergoes manual DNA phenylchloroform extraction, and this step is really crucial as automatic extraction of DNA does not generate enough leads and does not make enough material to proceed with the testing. Then the extracted DNA goes 2 steps of quality control in order to ensure that we have a really good starting material. It concerns first the control of quality of extracted DNA and also the absence of PCR inhibitors. When the sample passes through these 2 steps, then it goes for 3 different real-time PCR. Each sample is processed in 4 replicates per target, which means in 12 replicates because there are 3 targets. First target concerns bacteria, Borrelia burgdorferi sensu-lato, then Borrelia miyamotoi, and then Borrelia relapsing fever group. When the positive signal is generated, indicating amplification, then this amplicon is sent further for confirmatory sequencing in order to be sure that it is not a false positive sample. This method was used to analyze the ticks. Actually, in this study, we analyzed the ticks from Belgium and France. For the study, the whole ticks were mechanically gridded with glass beads and then extracted as indicated by phenylchloroform method. And this extracted DNA was analyzed by 2 methods. First one is HibriSpot. It's yet another method for simultaneous analysis of 7 tick-borne bacteria that are Rickettsia, Ehrlichia, Anaplasma, Francisella, Bartonella, Borrelii, and Coxiella. This method consists of a PCR followed with the dot plot and the Felix phage Borrelia test, another method that I just explained a few seconds ago. When we compare the results obtained with these 2 methods, we can see that 40% of analyzed ticks were negative, no detected pathogens. but 60% of them were positive for at least one pathogen. If we look to the HibriSpot results, we see that the only pathogen that was detected are Borrelia burgdorferi, because this method can only detect Borrelia burgdorferi, and 20% of tested ticks were positive for Borrelia burgdorferi. When we look to results obtained by Felis phage test, we can see that Borrelia burgdorferi is the similar positive rate, only 70%, but 60% were positive for Borrelia miyamotoi and 23% for Borrelia relapsing fever group. 25% of positive ticks were for two pathogens. And when you look to these results, the first that is really shocking is this unexpected high rate of Borrelia miyamotoi and relapsing fever in tested ticks. Previously, those types of Borrelia were barely tested, and we had the impression that those infections are extremely rare and just localized to some specific regions, and even there that they represent a very low percentage. Are those really unexpected, or we were not really aware that they're all around us? As I said, 60% of analyzed ticks were positive for at least one pathogen, and among them only 17% were positive for Borrelia burgdorferi sensu-lato, while the main test for uncovering Lyme disease are the tests for Borrelia burgdorferi sensu-lato only. Among positive ticks, 60% were positive for Borrelia miyamotoi that is not included in standard testing procedures. And this result is in line with those we obtained on human samples. Since July 2019, over 3,500 results from patients originating from various countries have been obtained. And testing included mainly late-stage and chronic patients, and the aggregated data are showing 30% of negative results and 70 positive, among which over 60% indicated the presence of specific Borrelia miyamotoi phages. With respect to obtained results, a question raised: are we searching for wrong culprit when using classic methods looking only for Borrelia burgdorferi? If you go back to the table I showed you at the beginning with the three major tests used, knowing that antibody is the test that is recommended worldwide. And when you compare it with the phage tests, you can see several advantages. First of all, direct evidence of Borrelia presence that is not linked to any kind of immune status, and it's direct. It's very sensitive and very specific. Can distinguish Lyme from relapsing fever strains, and can distinguish between active and non-active Borrelia presence. And these are major advances comparing to classical methods. Thus, in conclusion, seeing a high prevalence of Borrelia miyamotoi in tested ticks, further supported by similar percentages found in tested patients, one can hypothesize that the high failure rate of current two-tiered screening testing searching for Borrelia burgdorferi sensu-lato only may be due to the wrong testing target. In other words, the overall high expansion of undiagnosed Lyme disease cases worldwide might be linked to the screening choice focusing only on Borrelia burgdorferi sensu-lato and only rarely testing for Borrelia miyamotoi, while the later one seems to be much more prevalent. Further accumulation of data, both from the patients and ticks, should bring the answer on the question, are we searching for a wrong culprit? And searching for actual bacterial presence using phage-based testing might pacify the debate and controversies on testing choices and late chronic stage patients. And very importantly, this new type of technique can now be translated for different other pathogens that are not abundantly present in their host, and thus advance diagnostic and, of course, the treatment of those patients. I thank you very much for your attention, and we're available for your questions by phone, by email, and here if you have anyone. Thank you very much for sharing this.
Thank you very much for your wonderful presentation, ma'am. Does anyone have any questions regarding this presentation? Okay, and if anyone have any questions, you can always post it in the chat box.
Thank you very much.
Thank you very much, ma'am, for your presentation. Hello everyone, and wow, now I would like to display poster presentation from Kaisa from Poland. Just have a glance about this presentation poster for a few minutes. Yeah, hello everyone, and I would like to introduce our next presenter. Dr. Tala Singham. Can you hear me, Mr. Muhammad Tala Singham? Hello? Hello? Yeah, hello. Can you hear me, Mr. Tala Singham?
Hello, can you hear me?
Yes, doctor. Just give me a second and I'll introduce you. And you can start with your presentation. Hello everyone, I would like to introduce Dr. Tala Singham, and he is from University of Malaysia Sabah, Malaysia. And Dr. Tala Singham has graduated from Zhejiang University, China with MBBS degree in year 2019. After which he cleared US MEL exam step 1 in 2021, and he is currently master student in community medicine at UMS Malaysia. And he is currently in work of 3 major research projects, leading this particular one with the working in the team for the other two. And he has a passion for the community medicine, especially in public health. Dr. Tala, you can continue your presentation.
Sure, thank you. Hold on 1 minute, my presentation is opening up. See my screen. Is it visible?
Yes, Dr. Tala, you can continue your presentation. We can see your presentation.
Hello.
Hello. Yes, we can see your.
Hello.
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 Can you hear me?
Yes, we can hear you. Can you hear us, Dr. Tala?
I can't hear you. Hello.
Hello. Can you hear us, Dr. Tala?
Hello.
Hello.
Yes, can you hear me now?
Yes, we can hear you. Can you hear me?
Yes, now I can hear you.
Yes, ma'am. So continue your presentation.
All right. Yes, so hi everyone. I'm Dr. Mohammad Talha Zegam. I have done my MBBS from Xi'an Jiaotong, China. I'm currently pursuing a master's degree in community medicine at the University Malaysia Sabah. So this is one of the research projects that I'm leading right now. The title of the project is The Prevalence of Prehypertension in Children with Exposure to Biomass and Indo Pollution in Rural Sabah. It's a cross-sectional study. So first of all, I would like to tell you guys, where is Sabah? Sabah is basically an area in Malaysia is also known as East Malaysia, and it lies in the Borneo rainforest. So first of all, pre-hypertension, previously it was considered a gray area, but since 2006, it has been defined as its own disease, and it is defined as systolic blood pressure of 120 to 139 and a diastolic blood pressure of 80 to 89. The indoor pollution that I'm referring to in this study is the burning of biomass, specifically indoors in order to cook. And the indoor pollution, the word indoor here refers to environments in schools, homes, and public buildings and other similar places. So as many of you might know, biomass is considered the world's fourth largest energy source. Biomass is found vastly in Malaysia due to its tropical weather and its geographical location. It is estimated that around 6,370 million ringgits worth of energy comes from using palm oil annually. And Sabah being the second largest state that consumes and produces this product of biomass. In 2018, a research was done in Peninsular Malaysia that found that prevalence of pre-hypertension was 37.1% among 151 males. Last year, a study was conducted at my own university that found a similar trend of 31% of the students at my university had pre-hypertension. Literature signifies that there is an extremely high prevalence of pre-hypertension among the youth in my state, Sabah, leading to a dire need of additional research to be carried out to capture the risk factors for this newly developing disease, especially for their children. So my research questions that we are going to be answering by carrying out this research is, number one, is there any prevalence of pre-hypertension among the children aged 5 to 15 in rural Sabah? The second one is, if there is this prevalence, what is the level of that prevalence? And the third one is, what is the relationship between pre-hypertension and exposure to indoor pollution in rural Sabah? The objectives will be to assess whether there is any prevalence, the level of that prevalence, and what is the relationship between the prevalence of pre-hypertension and the disease. The research scope will include children that are aged 5 to 15 in order for us to find if there is a relationship between the exposure of indoor pollution and pre-hypertension. This is a cross-sectional study being conducted right now in Sabah. The blood pressure readings that we are taking right now we are taking using a pediatric sphingomanometer, and the indoor pollution levels are being measured using a dust tract. So this is some past literature that has been done. So in 2006, the definition of pre-hypertension was defined, as I have told before. And in 2013, among children, it was found that in Malaysia itself, there was about a prevalence of pre-hypertension of about 12.23%. The indoor environments that may have polluted homes, schools, and daycare centers. This is some past research. I will just leave it here for everyone to go through. Basically, the summary is that people have found out that there is a relationship between indoor pollution and pre-hypertension among mainly adults, but no study till date was ever done in the population of children, which right now is being conducted in Sabah. So my research methodology that we are doing is, it's a cross-sectional study again. Children of 5 to 15 years old are being included. The locations where we are taking the samples are the households in rural areas of Sabah. Again, rural areas because Majority of the rural areas in Malaysia, in Sabah, are the only places where biomass is being used to cook their food. So hence they have an exposure to it. The equipment being used is the pediatric sphingomanometer and the dust track. We are taking a maximum of 2 children per household, and a minimum sample size of 165 samples is being taken. And the inclusion criteria is any child of age 5 to 15 years old who has prehypertension, which is defined again as systolic blood pressure of 120 to 139 and a diastolic of 80 to 89. This is being done randomly. Again, now once we will be completed with our research, then the statistical analysis will begin. The statistical analysis will begin. Firstly, we will need to know that since this is a cross-sectional study, so the main numbers that we are going to be getting out of this is the prevalence of prehypertension in children and its association with indoor pollution. Prevalence will be calculated by measuring the number of cases divided by the number of total children being tested for it. Then the prevalence in each category of exposure and unexposure will be measured. The prevalence odds ratio can then be calculated. The analysis will be done using a chi-square test to determine if there really is an association between these two things. This is my dummy table that we are currently using while we are carrying out the research. We have included demographics such as gender, age, and 3 major races that are present in Malaysia, and a category for others. Blood pressure is being defined as either normal, prehypertensive, and hypertensive, and the exposure to indoor pollution is being noted. So the significance of my research is basically, first we need to know if there really is a prevalence of this prehypertension and identify high risk groups of children who can eventually have hypertension, as prehypertension will eventually lead to hypertension. We can adjust for additional risk factors that if we find out this has a proper association with indoor pollution, with prehypertension, we know that this is actually a risk factor. Then the results of this research will help us to prevent further complications. If we find out a certain group is high risk and this group particularly has high risk of prehypertension, we know that we can change that for them to become normotensive if we change their behavioral and life changes in the high-risk groups. This research will also decrease the burden on the Malaysian healthcare system, which is already very burdened, especially during these hard times of COVID. Thank you. And this is my phone number and my email address. If anybody has any questions, can reach out to me. Thank you.
Thank you very much for your wonderful presentation, Dr. Fala. Does anyone have any questions regarding this presentation? Yeah, if you have any questions, you can always post it in the chat box. And once again, thank you very much, Dr. Fala. And I would like to introduce our next speaker, Shareen Shahira. She is from USA. Can you hear me, doctor?
Yes, I can. Can you hear me?
Yes, ma'am. Just a second. Let me introduce you and you can continue with your presentation.
Yeah, sure. Thank you.
Hello, everyone. I'm introducing Dr. Shareen Shahira. She completed her PhD from Sri Chitra Jirunal Institute from for Medical Sciences and Technology, Kerala, India in 2017 and went to USA to pursue her postdoctoral studies. After 1 year of her postdoc at the University of Alabama, she is currently working as postdoctoral associate at the University of Massachusetts Medical School, USA since 2019 January. She has over 15 publications in peer-reviewed high-impact journals and has been serving as editorial member and reviewer for reputed journals. She presented papers at several national and international conferences and has got many accolades. Ma'am, you can continue your presentation.
Okay, thank you. Can you see my screen?
Yes, ma'am, we can see your screen.
Yeah, thank you. Yeah, so thanks so much for that kind introduction. So myself, Sharon Sahira, and I'm currently a postdoctoral associate at the University of Massachusetts Medical School. I thank the organizers for the opportunity to present at the International Conference on Public Health. So the title of the presentation is Stem Cells and Exosomes, Better Candidates for Treating COVID-19. Let me give you a brief intro on what I'll be talking throughout my presentation. So I'll give a brief intro on COVID-19, what stem cells are, what are the stem cell derived exosomes, how do these exosomes play a role in pathologies, and how we can use stem cells and exosomes as therapy for COVID-19. So I know we all are very much familiar with what COVID-19 is, how it spreads and everything, but let me give you a brush up your memory. So it emerged in the Wuhan city in China in December 2019, and it has been over a year now. And by that time, it has spread globally and has been considered a pandemic. And it has affected every phase of human population. And so the present treatment strategies involve using antiviral drugs and convalescent plasma infusion, and they are found to be effective in improving the symptoms. So now we know that a few vaccines have been approved at emergency use all over the world and is being administered in phases, and it might take quite some time for the whole human population be vaccinated. And till now, the scientists and physicians are trying to understand the actual mechanism by which this virus affects our body and how to have developed strategies to alleviate the symptoms. And we have seen throughout the infection that the elderly population and the people with underlying conditions are more susceptible to the infection and more prone to die from this infection. And according to WHO, it has infected more than 140 million people and killed more than 3 million globally, so which is a very huge number. Now, looking into a global map, you see here that the most affected countries include the US, the UK, India, and Brazil. And globally, all countries are affected. And the numbers, and we know that now more countries are seeing a second or a third surge, which we never expected. And the virus is undergoing mutations, which is found to be more which is having more property to transmit. So how does this coronavirus enter the cells? So this coronavirus has a spike protein in its outer body. And this spike protein binds to a receptor called the angiotensin converting enzyme 2 receptor that is present on the cell surface. Once they bind, they enter the cell inside the cell, and they inject their genomic material. And what this genomic material does is that they direct our cellular machinery to make copies of themselves. And that is how they replicate. And so our cell makes more copies of the virus, and they replicate in more number. Now, when you look at once we get infected with the coronavirus, the symptoms can vary from mild to severe depending upon the person. So the mild symptoms include fever, headache, body aches, dry cough, and some GI symptoms like diarrhea, abdominal pain. So whereas in some cases in people in the elderly population, as I mentioned, and people with underlying conditions, they can develop either stroke, acute respiratory distress syndrome, and even multi-organ failure resulting from inflammation. So what is so different with this virus is that we have not seen such a virus. We have not come across such a virus that affects all the organ systems in our body, right? So this is such a virus that not only affects the lungs, the acute, having like acute respiratory infection, but it affects all other organs, taken from the brain to the blood vessels, to the eyes, to the nose, you name it, and you can see infection in one or the other person. So it's quite a complicated and a complex virus where people are still trying to understand what the actual mechanism of infection by this virus is. So if you see all these organs, so one or the other organ is affected to some extent, and all these infections, normally patients will die of multi-organ failure. So of all these organs, the majorly affected one is the lungs. Why so? Because we know that the virus enters our body through nasal passages, airway passages, and normally when we have an infection, we normally get to see the upper respiratory tract infection. So this virus and our lungs are abundant in this ACE2 receptor through which the virus enters the cells. So that is one of the reasons why we see a lot of lung infection. Well, so what happens is that we know that the air passage takes place at the alveolus within the lungs. So when there is this infection, it causes a lot of, so once this virus enters the cell, it elicits an immune response. So our immune cells gets in to attack this virus. And so they secrete a lot of cytokines to attract more immune cells to fight this virus. Doing so, what happens is that there will be a cytokine storm, which increases. There will be a whole lot of cytokines that our body can't manage. As a result of this, what happens within the alveolus is there is a fluid buildup within the alveoli. So it results in a defective gas passage, gas exchange. So the patient will experience difficulty breathing, and then they will have to be intubated. And if it becomes more severe, then they have to undergo transplantation, and there is no other way of treating this. And the lung also experiences fibrosis due to the cytokine storm. Now, why is this COVID such a destructive illness? As I was mentioning before, when there is this, when the virus attracts the immune cells, they secrete a lot of cytokines, thinking that they are going to kill the virus and get the infection out. But what happens eventually is that a lot of cytokines are being produced more than our body or the organs can manage it. So this cytokine storm eventually leads to an inflammation all over the body and spreads throughout, resulting in multi-organ failure. That is why this COVID-19 is such a destructive illness, that it leads to such an inflammation that one treatment cannot improve the patient's symptoms. Now, how is this COVID-19 treatment work? So there are different strategies by which medical people treat these COVID-19 patients. First is using antivirus. They go and directly kill the virus. And then is the anti-inflammation, where we have a lot of cytokine storm. So to suppress this inflammation, we can give anti-inflammatories. And then we have the antibody treatments, where you have specific antibodies produced against the coronavirus. So they go bind and kill the virus. Now, all these treatment strategies are working, and some patients improve and some may not, depending upon the patient's genetic buildup. So now scientists and researchers are trying to see if there any other better treatment strategy without further improving the patient's symptoms. That's when scientists started looking into stem cells and stem cell derivatives. So what is the stem cells? We know that stem cells are cells that have the ability to renew themselves and make more of the soul-like cells by cell division, and they also have the ability to get differentiated into different cell types. So normally within the blastocysts, once the zygote is formed, the 16-cell stage called the blastocyst, all the cells are stem cells that can differentiate into all types of the stem cell, all types of cells that we see in our body. So scientists started thinking, why can't we use stem cells as a therapeutic strategy for treating COVID-19? Now, if you look into the different types of stem cells, we have like pluripotent stem cells, the embryonic stem cells, and the stem cells that we isolate from adult body. So in our body itself, we have stem cells throughout. So whenever there is an injury or something, these stem cells can respond to the stimuli and differentiate accordingly. And we know that the blood is another type of stem cells that give rise to all cells of the immune system. And we have other stem cells like the cardiac cells, nerve cells, liver cells. We have a small population of adult stem cells throughout our organs. Now, out of all these stem cells, the major or the most potential one is the mesenchymal stem cells. Why so? These mesenchymal stem cells are found in all types of tissues, and it is easy to isolate them. And another property of these mesenchymal stem cells is that they can be differentiated into different cell types when you give a specific stimulus. So depending upon the stimulus, mesenchymal stem cells show the property to get differentiated. So that is one of the characteristics that scientists are became more interested in mesenchymal stem cells. So now let me give you some idea about what these exosomes or extracellular vesicles are. Extracellular, as the word defines, it is something that comes out of the cell or comes from the cell, but not a cellular material. So here you see we have, like, depending upon the nature by which it is formed, the composition and the size, these extracellular vesicles are divided into apoptotic bodies, microvesicles, and exosomes too. So let me tell you, these apoptotic bodies, we know the cells undergo apoptosis, that is a programmed cell death. So when they undergo apoptosis, what happens is that they form blebs and collapses. So those bodies are called the apoptotic bodies. So they are of no use. They eventually get destroyed within the cell, within some other cell. And then we have the microvesicles. They are little over a size of 100 nanometer to 500 nanometers. So they form the microvesicles. And they also carry a lot of information within the microvesicles. So scientists are trying to understand more about microvesicles now. And the most popular one is the exosomes. These are the smallest of the extracellular vesicles that are being produced by the cell or secreted by the cell. So because its size ranges from anywhere from 30 to 150 nanometer, and they carry biomolecules like proteins, nucleic acids, lipids, everything. And what these extracellular vesicles can do is that they can circulate through the blood and get transmitted to a recipient cell. So once they get transmitted to a recipient cell, they exchange the material that is inside these vesicles, and they get injected into the recipient cell, and they can alter the fat of the recipient cell. So this is how these extracellular vesicles work in our body. Now, let me give you a brief history of exosomes. So exosomes were discovered in the year 1983. And initially, when it was discovered, the scientists thought that it is just a vesicle that is meant to carry cellular waste out of the cell. That means such a sack or a garbage bin that just takes the waste materials out of the cell. And the word was coined by Ross Johnstone in the year 1989. So this is how the exosomes look like under transmission electron microscopy. So it has a flattened football-like structure with a depression in the center. So this is how, so people are trying to understand more about how they are, what their morphology is, what their composition is. People are trying to understand more about these tiny vesicles that are being secreted by the cell, eventually thought to be a cellular waste. Now, let me give you a brief, so how are these exosomes produced inside the cell? So within the cell, small vesicles are formed, and these vesicles aggregate together to form a multivesicular body. And what happens is that once these multivesicular bodies are formed, they fuse with the plasma membrane, and they secrete all these nanovesicles out of the cell.
So the pathways by which these microvesicular bodies fuse with the plasma membrane is under investigation. Many proteins and many pathways have been implicated, how they are formed, what helps them fuse with the plasma membrane, what determines their formation, all are under study now. So now a closer look into exosomes. I told that this is very small vesicles, like a nanoparticle, ranging from 30 to 150 nanometer, right? So if you look into this exosome, it has a lot of things inside. It is not just a very little molecule with nothing in it. You see it has a lot of membrane. It's a lipid bilayered membrane, just like our cell membrane. And it has a lot of receptors, which actually helps us markers to identify these exosomes. And inside, you can see a range of bioactive molecules like proteins, lipids, microRNAs, long-coding RNAs, and different set of molecules because it is formed inside the cell. So what it does is it carries a tiny bit of the parent cell inside it. So what it is said is that if you study the exosomes, you will get to know the status of the parent cell from which it is being formed. So say if the exosome is secreted by a pathological cell or a cell that is undergoing some stress or anything, then the exosomes will have those characteristics. And those exosomes will be totally different from the exosomes that are isolated from a healthy cell. So exosomes are a tiny mimic of the parent cell from which it is being formed. That is why these molecules are kind of getting so much of attention from the research field, because by looking into the exosomes, we will understand whether our body is going through a healthy state or a pathological state. So that is why these exosomes are being studied a lot. Now, as scientists are trying to understand more about exosomes, now exosomes are being implicated in all pathologies. Exosomes like the senescence-related exosomes, it has been found that the exosomes isolated from an older patient is very different from the exosomes isolated from a young one. So, and these exosomes, or the senescence-related exosomes, are associated with cardiovascular disorders, neurological, diabetes, and other age-related pathologies. People are trying to understand more, and these exosomes are being implicated in all diseases. Let me give you a brief difference between the young and the exosomes isolated from the young and the aged individuals. So in the young individual, we have normal levels of EC, whereas in the aged population, we can see an increased extracellular vesicle secretion. Now, in the normal condition, they don't mediate any pathological changes, whereas in the aged individual, they mediate or accelerate the age-associated pathologies. And the thing is that these extrasomal microRNAs, as I was mentioning, the exosomal composition could act as biomarkers in identifying different disease conditions. So, and they vary a lot depending upon the status of the cell. That's one main thing we need to understand about the exosomes. Now, how is these exosomes can be related with COVID-19, right? So this is a microvesicle. This is a nanovesicle, which can carry molecules from one cell to the other. So studies found that these exosomes can actually carry the ACE2 receptor, which is actually the receptor that helps in binding the virus. So say one cell doesn't have a receptor, these exosomes can carry the receptor from the receptor containing cell to another cell. And so this cell now have the ACE2 receptor to bind the virus. Now this cell can get infected. And another thing is that, so these virus particles get dissociated into its individual membranes inside the cell. So these exosomes can carry those individual components and take it to another cell and infect it. So these exosomes play an important role in increasing the infection within the body. And it was found that when the exosomes from a virus-infected cells were cultured with a non-infected cell, it was found that they could elicit an immune response. So we don't need, the exosomes are enough to elicit an immune response, which means that these exosomes carry something inside, something of the virus inside them, so that they are able to infect another non-infected cell. Now, how can we use these exosomes as a therapy for COVID-19? So as I told initially, mesenchymal stem cells are one of the major stem cells that scientists look into how it can be harnessed as a therapy due to many reasons, because these cells are found to be anti-inflammatory, anti-fibrotic, antioxidant, and can promote angiogenesis. So these mesenchymal stem cells is used in many preclinical and clinical studies as such, and they have come up with these characteristics for these mesenchymal stem cells. And they have been used in a range of diseases, starting from neural, heart, liver, intestinal, lung. Mesenchymal stem cells has been used in every single disease. And one other thing that makes that more potential is that it can modulate the immune response and by reducing the inflammation. So as I mentioned, the exosomes that are derived from the cells specifically mimic the parent cell. So the exosomes from the mesenchymal stem cells should elicit the same properties as the mesenchymal stem cells. So that's why scientists are more interested in using these mesenchymal stem cell derived exosomes as a therapy. Now, what does these mesenchymal stem cells or the exosomes do once they are injected into the patient with COVID-19 infection? So what these mesenchymal, so when we have the infection, we have macrophage accumulation and the activation and the production of cytokines, and there is a cytokine storm happening within the organ, right? So what does this mesenchymal stem cells do, and mesenchymal stem cells or their exosomes do is that they block the cytokines and they prevent the resulting, that is acute respiratory distress syndrome. They prevent the formation of this and prevent the multi-organ failure. So cytokine storm is a major thing that culminates in organ failure. So if we are able to effectively block the cytokine storm, we can improve the symptoms of the patient. Now, there has been a lot of studies happening with using the COVID-19 patients administering this mesenchymal stem cells. One study is human umbilical cord-derived mesenchymal stem cells. When they injected mesenchymal stem cells into COVID-19 patients, they found that they could significantly improve the symptoms of these patients. And the peripheral lymphocytes were increased and the C-reactive protein decreased in these patients. And they found that the cytokine levels decreased within these patients, which significantly improved the health of the patient. Now, these are some other studies that have reported improvement using the mesenchymal stem cells. Now, there was one other study that used exosomes derived from the bone marrow mesenchymal stem cells as a treatment for COVID-19. So they called these exosomes as ExoFlow. They injected exosomes into the patient and found that they increased the survival rate and also improved the symptoms of these patients and improved the absolute neutrophil count. So these exosomes are actually cell-derived, but they are not cells. So the adverse effects that are associated with using cell therapy is removed when we are using the exosomes, because owing to the safety profile, the capacity to restore oxygenation, downregulate cytokine storm, and reconstitute immunity, this ExoFlow is a promising therapeutic candidate for severe COVID-19. Now, these are some of the clinical trials that has been registered using mesenchymal stem cells as well as the different exosomes. So there's a lot of study going on to understand whether we can harness the potential of exosomes or mesenchymal stem cells for use in treating patients with COVID-19. Now, one another feature of these exosomes is that we can engineer the exosomes. How can we do that? A study found that when we use 293, this is a embryonic kidney cell, and what they do is they transfect it with the ACE2 receptor so that their membranes start to express this ACE2 receptor. And when you isolate the exosomes or the extracellular vesicle from that, these vesicles express the ACE2 receptor. And then they used another cell, that's an immune cell, the monocyte cell, to express the cytokine receptor. And they isolate the exosomes from these immune cells, and those express the cytokine receptor. What they did was they fused both these vesicles. They found that the newly formed vesicle now express both ACE2 receptor as well as the cytokine receptor. And now they did some experiments and found that these engineered vesicles will compete for the virus and the cytokines. So what happens if you give this engineered exosomes into the body? They will fight with our cells for the virus, so that virus infection is reduced, and also sequester all the cytokines that are being produced. So there will be reduced cytokine storm, and there won't be no more virus will be there to infect other cells. So this can be employed as a technique, as an improved technique, so that there won't be any, this is like we are engineering the exosome, so they doesn't have any adverse effect, or we are not having any bioactive molecules in the exosomes. We don't have to worry about, oh, what the composition of the exosome is going to be. Like, because we know that what the exact composition of the exosome and what it is exactly going to do within the body. So that is the most important, that we can engineer these exosomes and do what we want them to do. So to conclude my presentation, I would say this COVID-19, we have been seeing that it has a wide range of symptoms. Depending upon the patients, it ranges from mild to the severe illness, and it all depends upon the patient genetic makeup. Now, the stem cells and the stem cell derived exosomes have exhibited ability to improve these COVID-19 symptoms. And we found that the exosomes, or the engineered exosomes, can be a better therapy for severe COVID-19 patients. The superior safety profile, the stability, and the scalability makes exosomes a practical therapeutic option for COVID-19. Thanks so much for the opportunity, and thank you for listening.
Thank you very much for your fabulous presentation, Dr. Sherry.
Yeah, if anyone have any questions, I'll be happy to take.
Does anyone have any questions regarding the presentation? Yeah, you can always post your questions in the chat box, and I will direct them to the speakers. And I would like to introduce our next speaker.
Before I go, I would like to thank Dr. John Surendran, the Senior Scientific Coordinator of United Research Forum, for giving me the opportunity, and thanks so much. Thanks so much for the opportunity. Thank you.
Thank you very much for your presentation, ma'am.
Thank you.
Yeah, and hello everyone, and I would like to introduce our next speaker, David Kaufman. Can you hear me, sir?
I can hear you. Can you hear me?
Yes, sir, I can hear you. Just a second, sir. Let me introduce you. And,
sure.
You can continue with your presentation. Hello, everyone. I'm introducing David Kaufman, and he is from USA. David Kaufman is a business coach and a top 100 keynote speaker, author, and trainer. David is the president of Empowering Small Business, an international business coaching firm specializing in helping business over systemize their business to that they can find freedom in their business, so they can spend more time with their family and friends. David is handpicked by Zig Ziglar family to carry on the legacy of American legend Zig Ziglar. David is an expert in human behavior, a master trainer, one of the 10 in the world of this model of human behavior, and will be sharing how to perform at a higher level in sales, communications, and relationships by understanding the 4 basic personality styles. And get ready to discover things about yourself and others that will take you to the next level of performance. So you can continue with your presentation, sir.
Thank you. And you're going to have to make me
yes, sir. I'm
shareable.
One second. Yes, sir. Now you can share your screen now, sir.
Okay, can you see the screen?
See your screen. Yes, sir. We can see your screen.
Okay. All right. Thank you so much for having me back. It's a pleasure to be here. My name is Dave Kaufman, and it's going to be hard to follow Dr. Tala and Dr. Shireen because my presentation is a little bit of a different type. It's not a medical presentation, but it's more of a psychological, a human behavior presentation. And so I want to share with you what I think is one of the most transformative messages, one of the most transformative tools that you can use in how you learn to communicate and relate to your patients, to your fellow workers, to your nurses, to each other. And wherever there's two people together, what I'm going to share with you is going to help you to relate better with other people. So let's see if I can forward my slide here real quick. I want to ask you a question. I am a motivational speaker, so it's not a medical presentation, but more of a motivational, it's an inspirational type. But I want to ask you a question. What is it about winners that make them win? What is it about winners that make them win? We are all winners here today, right? We're all winners. What I've discovered in studying humans and their behaviors, and I've interviewed hundreds and hundreds of very, very successful people. One thing that makes them to win is they take massive action. They take massive action. They don't wait for, they're the ones that develop new things. They're the entrepreneurs. They are the winners. And so I wanted to just kind of set the stage with that idea of you taking massive action at whatever you do it to the best of your ability. And I know I don't need to tell you that, but I want to just encourage you to even do more work, even do more research, to go the next mile, to do more than what you think you are doing now. So I wrote 4 books. The first one was Freedom to Succeed. I'm not going to spend a lot of time promoting my books, but you can get them on Amazon. And the second book became an Amazon bestseller, People-Centered Leadership. I love people. There are some people that like research. There's some people that like excitement. There's some people that like people. And there's some people that really like to do things, to make big things happen. And that's what we're going to be talking about today. I also wrote a little book on becoming a great leader. I love to develop leaders around the world, and I like to help them develop other leaders. You're not a leader until you develop other leaders. And then the last book I wrote is called Seeds, and it's kind of a story form for entrepreneurs to learn how to plant the seeds of greatness that God has already put inside of you and to make them grow into something special. You can order books on Amazon, or you can call my office, or you can visit my website, empoweringsmallbiz.com, and order them off of there. So I would invite you to do that. And again, I'm so thankful for the faculty for having me back. I know I'm kind of a different type of presenter, but I promise you I'm going to be 3 things in this presentation for you here today. I'm going to be educational, entertaining, and engaging. Okay? That's my 3 promises for you here today. So what I'm going to talk to you is about what we call the model of human behavior. And I want you to look at this, and I want you to remember this model that you see on the screen here. And this is the completed model, and I'm going to tear it apart and rebuild it here in the next couple of slides so that you understand how to use it. Doctors will know how to approach and how to interact with their clients a little bit better, their patients a little bit better, if they understand the model of human behavior. Nurses will be able to care more compassionately with their patients if they understand what I'm about to teach you here in the next hour. I've been given an hour to teach you this. And so some of you may have already heard me last time that I was on the forum, but this is one of the most transformative tools that you can use in your medical practice or in your healthcare practice, I believe, that will help you to relate and communicate to other people in a more effective way. So we notice that there are 4 types of personalities. There's the D type, the I type, the S type, and then the C type. I'm going to tell you what those 4 types are later on in the presentation. But I want you to remember this model, and the next slide, I'm going to break it apart and we're going to rebuild it to show you how to use it. So everyone is wired differently. To understand yourself better, ask yourself 2 questions. The first question being, am I more outgoing or am I more reserved? Okay, so we all know what outgoing is. We all know what reserved type of a personality is, but here's just a little bit more to help you understand a little bit deeper about what is outgoing and more reserved. Outgoing people tend to speak and move with high levels of energy. Their gestures and facial expressions have more passion than more reserved individuals. Reserved people tend to speak more quietly, less forcefully. Their gestures and facial expression seems more guarded. They're a little bit more guarded. So the outgoing people tend to speak high levels. They're out, they're big, their facial expressions light up. Reserved people tend to be a little more guarded. Their gestures are going to be in front of them a little bit more. So that's, one way that you can tell the difference between outgoing and reserved type people. Here's a little bit more. Outgoing, or the active type of personality, is fast-paced, involved, energetic, optimistic, positive, enthusiastic. Their focus is on talking things out. They think, or they process their thoughts by saying words. To a lot of doctors, to more of a reserved, to maybe high C and S type, that seems foreign to you. But outgoing people tend to focus on talking things out. They process their thoughts by speaking words. The reserved, or the more passive type, are about their slower pace. They move slower, they make mistakes slower. They're cautious, they're concerned, they're reluctant, critical thinking, careful, discerning. Their focus is on thinking things through. I would imagine that a lot of the attendees here at this conference are more of an reserved type of personality. These are the people that think more than speak. Okay? Outgoing people speak more than they think. Does this make sense? The second question is, am I more task-oriented or people-oriented? Now, this is a little bit harder to understand, to discern, to determine, because all of us like to get things done, and all of us like people, most of us. But we like task more, or we like people more. So let's talk a little bit more about what a task-oriented versus a people-oriented person is like. A task-oriented people tends to focus more on the job or the process or the goal to be accomplished. They seem to be less influenced by the opinions of others. In other words, they don't really care what you think. They just want to get the job done. They want to complete the task. They want to conquer the challenge. They are more logic-based in their approach. They're a little bit more logical. They're more hands-on than the more people-oriented. People-oriented individuals tend to enjoy the company of others and seem to focus on the people as being the priority rather than the project or the process at hand. They seem to be more influenced by the opinions of others, less fact-based, and more sensitive or emotional. A little bit more about the task-oriented. And by the way, if you have questions, please put it into the chat box. I will have time at the end to answer any questions that you might have about this. So please enter into the chats. Okay, so task-oriented individuals are all about form, function, programs, plans, projects, processes, research. Their focus is on getting things done, completing the task. People-oriented individuals, however, are about relationships, caring, sharing, emotions, feelings, friendships. Their focus is on how other people feel and how they want to relate to each other. So if you ask yourself those two questions, are you more outgoing or reserved? So go ahead and answer that question. And by the way, I want you to answer that question about me in the chat right now. Am I more outgoing or reserved? Just by what you've observed from me right now, my hand gestures and everything, am I more outgoing or reserved? Type it into the chat right now. What do you think? Outgoing or reserved? Go ahead. Dr. Salim says outgoing. That is correct. I am very outgoing. I have never met a stranger. I love people. I like to talk to people. I'm very outgoing. Okay, thank you everybody for that. The second question that I want you to ask about yourself is on the screen right now. Am I more task-oriented or am I more people-oriented? Ask that question about you. Answer that question about me in the chat. Am I more task-oriented or am I more people-oriented? What do you think? Am I more people-oriented or task? I'm curious. Be careful because it's not what it seems a lot of the time. Let me see what you said. Okay, everybody's saying I'm more people-oriented. Actually, when I do the scientific assessment, I am about that much more task-oriented than I am people-oriented, but it's my task right now to be people-oriented because I'm presenting. So I come across as more people-oriented, but if you come work for me on my team, you will soon discover that I am just a little bit more task-oriented than people-oriented, but I am extremely people-oriented as well. So I'm extremely outgoing and equally task and people-oriented. This will make sense coming up very soon on the screen. Next slide shows the completed model of human behavior once again. So here's the two questions. Am I more outgoing or reserved? You all said that I am more outgoing. I asked the second question, am I more task-oriented or people-oriented? You said people, but I am actually just a little bit more task-oriented. So outgoing and task-oriented puts me into this quadrant. Outgoing and task puts me into the D quadrant, okay? Now, maybe some of you are outgoing and people-oriented. That would put you into the I type personality quadrant. Some of you might be very reserved, but people-oriented, and that would put you into the S-type quadrant. I'm going to share with you later on what are these different types of personalities, so please bear with me and be patient. The reserved but task-oriented is a high C-type personality. And I would guess that a lot of people in this forum here today are going to be the high C-type, because these are the cautious, calculating, competent, critical thinking, careful, cognitive, conscientious type of a person. But here's what I want you to understand. Every single one of you are a unique blend of these four types. Every human being on the planet has a unique blend of all four personality types. So while you may be primarily a high C, you also have D, I, and S type personality in you as well. So let's dive into it, and we're going to look at the D type first. The D type, these are the outgoing, task-oriented individuals. They're dominant, they're direct, they're demanding, they're decisive, they're determined, they're doers. They like to do things. These are the people that see the big picture. These are the entrepreneurs. These are the business owners. They change the world with their big ideas. Their color is green. Green means go, it means growth, it means life, it means energy. Their symbol is the exclamation point. So Donald Trump is a high D-type personality. Donald Trump does not ask questions, he makes statements. So that's why we have the exclamation point as their symbol. The I-type personality is very outgoing and people-oriented. These are the inspiring, the influencing, the impressionable, the interactive, the impressive, the interested in people type. They're very excitable. They love excitement and adventure and danger. That's why we have the color red for the I-type personality. These are what we call the sports cars of people. They're fun, they're exciting, but they're not all, sometimes they are illogical, okay? They're fun-loving, but not always very logical. And their symbol is a star because they're the star of the show. They love recognition, approval, and popularity. And then we move down to the S-type. The S-type are the reserved and people-oriented type of individuals. They're supportive, stable, steady, sweet, status quo, and shy. Their color is blue. Blue is the universal color of calm. These are the calm, the very loving, careful type of person. They're like the Mother Teresas of the world. These are the nicest people in the world when their primary personality trait is the S-type. Their symbol is a plus and minus sign. What do you get when you get a plus and minus? Positive and negative, you get a neutral. They can go either way, whatever you want. They're very supportive type of a personality. And then you have the C-type. Their color is yellow. Yellow means caution, slow down, think twice, be careful, research it. They're cautious, calculating, competent, conscientious, contemplative, and careful. They have a question mark because these are the type of personalities that ask lots of questions. They want to know quality answers, value, and excellence. They love research. They love knowledge. They want to learn more. And so you can understand, as a team, you need people that have their highest predominant traits in all four types. The perfect team to do research is a DISC. 4 people, 1 D, 1 I, 1 S, and 1 C. And that way you get a 4-dimensional look at that research or project when you're working on a project. Now let's go deeper into the D-type personality. I'm going to put a bunch of words up here that describe the D-type. The last one is in red because it's a harsh word, but everyone will have one harsh word. So the D-types are very dominant, demanding, direct, determined, decisive. They're doers, director, dogmatic, dreamer, diligent, dynamic, but they can be very defiant. Imagine telling President Donald Trump what to do. He's going to say, no, you do it. Don't tell me what to do. I tell you what to do. That type of personality is only about 10% of the world are high Ds. We're going to notice that on the next slide. So let me move the pictures away so I can see. The percentage, and again, this is an estimation, but when I do this in a live audience, we usually assess everyone in the audience. I've done it with 400 people in the room, and about 10% of the room was 10% was high Ds. Here's some examples. Some people that you might know: Donald Trump, Judge Judy, Dr. Phil, Hillary Clinton. So if you watch an episode of Dr. Phil on TV, you'll notice that he's very direct. Feelings really don't matter to Dr. Phil. He just tells you like it is. It is what it is. You change it if you want to, but I will believe what it is. Dr. Phil is very much a high D. There are 3 fuels that drive a high D type personality. And by the way, personality does not depend on male or female. I've seen very high D males. I've seen very high D females. In fact, Hillary Clinton is a very high D type personality. Here's the three fuels that drive the high Ds. It's what gives them energy: challenge, choices, and control. Challenge, choices, and control. There was once a couple, a married couple, that came to one of my seminars, and they said that they have a 9-year-old high D child, 9 years old, a boy, a high D 9-year-old child. And they said that at 9 o'clock at night, when it's time to go to bed, they tell their son, it's time to go to bed, it's 9 o'clock. And the high D son says, I don't want to go to bed. Why do I have to go to bed? Do you want to fight? That kind of an attitude from a 9-year-old high D child. So I told the parents, there's a very simple way to fix this problem. I said, give the 9-year-old a choice. Tell him he can go to bed at 8:30 or 9 o'clock, but it's your choice. What do you think the child chose? 9 o'clock or 8:30? Put it into the tab. Go, go, go. Put it into the chat right now. 8:30 or 9 o'clock? What do you think the child chose? Let me check. What do you think the child chose? 9 o'clock. The child actually chose 8:30. Okay, he chose 8:30 because he likes choice and he likes control. So the child thought, they want me to go to bed at 9 o'clock. I'm not going to choose that. I'm going to choose 8:30 because I want to have the choice. I want to have control, and I conquered the challenge. I won. That's how the child thought. It's so interesting. Even at a very young age, you can start telling the personality types of young children. Yes, 8:30 is the correct answer for that child. And that is a true story. It happened in one of my seminars. They called back about a month later and they said, David, this is some of the most amazing information. It's helping us to understand how to raise and teach and communicate with our 9-year-old son. So give a high D on your team a lot of challenge, choices, and control. You have to be careful that you don't give them too much control, because then they will take over the whole project. The high Ds are very, very strong-willed people. You can see there's a lot of things that high Ds make good: administrators, athlete, boxers, fighter pilots, government agents, truck drivers, motivators, private investigators. There's a whole list here that you can see that high D types make. They're good at doing these types of tasks. Okay, let's go a little bit further. Let's look at the high D types. Like activity. They like bigness. They like challenge. They like competition. They like to debate. They like doing things. D types can be critical of poorly performed tasks, complete amazing amounts of work, may believe that approval and encouragement lead to complacency. They tend to seek leadership roles. They could need to learn to delegate responsibility. They want to do everything themselves. They want to be in control. So they need to learn how to delegate responsibility a little bit better sometime. They might unintentionally intimidate people. Goal-oriented, they're intense, they're performance, they're conscious, they're self-confident. And let's look at the next slide. D types don't like indecision, talk without action, activities without a goal, slow activities, unproductive people. They don't like being told what to do. D types want you to be quick, confident, productive, to the point, specific, and driven. D types, in your practice, your marriage, your school, your business, your team, wherever you are, who are dominant, that's the D, that's the nomenclature for when I say D, you think dominant. So D types who are dominant enjoy making decisions to solve problems so they can reach their goal. The D types are very goal oriented. The problem with a high D type is they're so focused on the goal that they forget there's people between them and the goal. And sometimes they run over people. They hurt people's feelings. Okay. Now let's look at the high I type, the fun-loving, the exciting type. These are the inspiring, the influencing, inducing, impressive, interesting, impressionable. They're important, or they think they are. They're interchangeable. They're interested in people. They're imaginative, and they are impulsive, but also they have a challenge of being illogical. They're not always logical. They do things because of excitement and fun, but sometimes they get themselves into trouble because of that adventurous spirit, that fun-loving spirit. But everyone loves to be around a high I-type personality because they're fun, they're exciting, they like to do adventure, they like to make people laugh, they're very fun to be around. Percentages of population is about 25 to 30%. Here's some examples. A lot of comedians, entertainers, movies. Jim Carrey, Will Smith, Oprah Winfrey, and Ellen DeGeneres are all, their primary personality type are high I's. Now remember, everyone is a unique blend of those 4 types of personality. They also have 3 fuels that drive them. If they don't get the fuel of recognition, approval, and popularity, they are going to start acting out in a way that they will receive recognition, approval, and popularity. Recently, I was teaching a group of about 4,000 school teachers on this very presentation, and they started realizing that's why little Johnny or little Sue starts acting out in classes, because they're not getting enough recognition, approval, and popularity. So they start misbehaving. They start whispering. They start throwing paper airplanes in class, trying to have fun. And they started understanding that's why they're doing that. And so, like I told you, this is one of the most transformative tools in learning how to relate and communicate and care for, in your case, with healthcare, to provide compassion and to understand them as a person, not just a body that needs healing, but as a person with feelings and emotions that are different from every one of your patients. So I-types make good actors, airline attendants, auctioneers, broadcasters, clowns, preachers, politicians, teachers, telemarketers, telephone operators, and wedding consultants, just to name a few. I-types like exposure to people, lots of activity, making people laugh, short-term projects. They like to be on the go. They don't like to do the same thing over and over and over and over again. They want to have lots of different activities. They like prestige. They like to be noticed. I-types enjoy making people happy. These are the comedians, the entertainers. They like to see people laugh, but yet they are very emotionally driven. They can be very high as a kite or low as a skunk. Now, that is an American term to describe high emotions versus depression. So high I-types are roller coasters of emotions. They go up and down depending if they get their fuel. Okay, so if they don't get their fuel, they get depressed, or they feel like nobody likes them, so they get depressed. But if people laugh around them, their energy level starts going up. They may believe that talking and doing are the same thing. They might need to focus more. They take pleasure in playing while they work. I-types are fun to watch. They're great starters. They're quickly bored. They're likable. They're prone to exaggerate. They can make a fish that is this long sound like it's this long with just their words that they say. Everything is exaggerated. They're fun to be around. They're easily excitable. I-types don't like being ridiculed. They don't like being ignored. They don't like looking bad. They don't like being isolated, doing repetitive tasks and constraints. I types want you to be fun, responsive, stimulating, positive, upbeat, enthusiastic. I types in your practice, your marriage, your school, your business, your team, wherever you are, who are inspiring. When I say I, you think inspiring. The inspiring is the nomenclature for I. Love to interact with people so everyone has a great time. I's love to have a great time. You wouldn't have a party if it wasn't for the I-type personality. The I-types, they are the party. They bring life to the party. They bring enthusiasm and excitement to your team. Now let's look at the nicest people in the world. These are the S-types. They're supportive, they're steady, they're stable, secure, serve, sweet, submissive, shy, status quo, sentimental, sameness. They like everyone to be in harmony. They don't like confrontation. They don't like disruptions. They want harmony. They want peace. They want everything to be the same, but they also are suckers. Now, let me explain why I say they're suckers. Suckers is an American term that they're easily manipulated. They're easy to take advantage of because their nature is to say yes. Their nature is to support. Their nature is to nurture you, to help you. And so they're very easy to take advantage of. And so I want us to be very careful that we don't take advantage of the S-type because they are the sweetest type of personalities. So that's why we call them a sucker. You may not understand that term because that's an American slang term. The percentage of population is about 30 to 35%. A lot of nurses and doctors have a high S type. It's usually their second highest personality trait because they care for people, but they have a scientific brain. That's the C type coming up next. But their compassion and their desire to help people comes from the S type personality. Here's some examples. Dr. Martin Luther King Jr., Paula Abdul, Mother Teresa, Gandhi, they were all high S-type people. They care deeply about how you feel, and they would rather hurt themselves than to hurt you. 3 fuels for a high S-type person: appreciation, security, and assurance. They want to be appreciated, and they will show appreciation more than others. They want to have security and they will give security as well. They want to have assurance that they made the right decision, that they're doing the right thing, that and they want to also assure other people. S-types make good childcare workers, counselors, diplomatics, flight attendants, funeral directors, nurses, managers, painters, pharmacists, pastors, planners, veterinarians, technicians, supervisors, secretaries, school teachers. I love the S-type personality. S-types like peace. They like stabilizing things. They like helping others. They like friendly environments to finish the job, teamwork. S-types consider the feelings of others. They will support you. S-types like to take their time. They don't like to be rushed. They want to make sure everyone is taken care of. They're very sentimental. They stay with proven methods. They don't like to try new things. They don't buy brand new products that are just brand new. They want to make sure that it's going to be a good product before they purchase things. They want to be appreciated. S-types are agreeable. They're loyal friends. They're great finishers. They're compassionate decision makers. They're concerned about how to start, and they really are the nicest people in the world. I love the S-type. S-types don't like insensitivity. They don't like misunderstandings, surprises, intense conversations, sarcasm. They don't like to be pushed. They don't like to be rushed. S-types want you to be kind, pleasant, caring, patient, understanding, and gentle. S-types in your practice, marriage, school, business, team, wherever you are, who are supportive. Supportive is the nomenclature for the S-type. So when I say S, you think supportive. They seek to maintain accepted routine so they can make sure everyone is comfortable. Now let's look at the C-type. They're very cautious. They're very competent, cognitive, careful, calculating, critical thinking, compliance wanting, conscientious, correct, conformist, consistent, and they can be cold. Now, let me explain what I mean by cold. A lot of times they're so focused on things being done correctly. They want the research. They want systems. They want things to be right, that they forget that other people have feelings and emotions. And when things are not right, the C-type is quick to think that's not right. And it can hurt other people's feelings because they can come across as indifferent to other people's feelings. Okay, so most of the doctors are going to be high C-type personalities. Okay, most of your nurses are going to be CS-type personalities, and thank God that they are, because I don't want a high I-type doctor working on me. I don't want an excitable type of a person. I don't want an adventuresome doctor working on me. I want a high C. I want somebody that's cautious, competent, cognitive. I want a person that doesn't allow his or her emotions to affect the way he or she thinks about fixing my body. Does this make sense? I want them to be cognitive, careful. I want them to be cold. I want them to focus on the facts, not the feelings. I want them to focus on the correct procedures rather than the emotions of my family about my health. Does this make sense? I want them to be correct, compliance wanting, conscientious, consistent. I don't want a high D as my surgeon. A high D will just rip me open and grab it and go. He's finished, okay? I want a high C that is very careful, very precise, very, very careful, calculating. I want them to think. Thank God for the S-type personalities. Let's look a little bit more at the S-types. And if you have any questions, please type them into the chat box, where we can get them at the end of this presentation shortly. Percentages of population is about 20 to 25% of the world is a high C-type. Here's some examples. Diane Sawyer, she was with ABC News. Clint Eastwood. Next time you watch a Clint Eastwood movie, watch how many times he smiles. Maybe 2 or 3 times the whole movie. And if he does, only one side, just a very cold smile. But all of his movies, he is the character in the movie that says, you were wrong and you will pay for it. He was very precise. He was the one that wants everything to be right. Tiger Woods, the golfer, Martha Stewart, they're all high C-type personality. Here's the fuel that drives a high C-type. Quality answers. They love research. They love value. They love excellence. They love statistics. They like to research projects. S-type or C-types make good accountants, architects, artists, authors, bankers, doctors, dentists, engineers, finishing carpenters, inventors, lawyers, librarians, professors, pilots, physicians, surgeons, philosophers, even photographers, just to name a few. C-types like consistency, they like detail, they like excellent work, creativity, perfection, getting it right. They think in concepts, they have lots of questions. They might seem uncaring. They want to understand. They want to exceed expectations. They see the pitfalls. They see what could go wrong instead of what could go right. They think negatively about things. They don't think about the possibilities. They think about the liabilities. And thank God for the high C, because if there would be no high Cs, there would be no architects. And these buildings would be big and grand and bright colors, but when the winds of hurricanes would come, they would fall over. It's because of the C's that we have strong buildings, strong bridges, because they're the engineers. They think critically about things. They don't think positive about things. They think critically. They think, what could destroy this? So let's create it strong enough so that it can withstand a hurricane, a tornado, or a flood. So C-types are difficult to please. They're focused on excellence. They're dedicated to the task. They're self-sacrificing. They're very logical, and they're attentive to details. C-types don't like being criticized. They don't like when you criticize them because they're right. They've already researched it. They've already done the proper research and came to a logical conclusion. So when you criticize them, they don't like it. They don't like mediocrity. They want you to be 100% correct. They don't like illogical changes. They don't like mistakes, unnecessary interruptions. They don't like ambition without a plan. C-types want you to be open-minded, accountable, structured, accurate, analytical, reasonable. C-types in your practice, your marriage, your school, business team, wherever you are, who are cautious. So when I say C, you think cautious. They seek the facts and follow procedures so they can uphold principles. They want everything to be done correctly, precise, perfectly. So here it is again, the model of human behavior. So remember, every one of you are a unique blend of those four types, but in the chat, I want you to type in right now, what is your primary one based on today's presentation? What do you think your primary personality type, your number one, your highest one? Are you a D, an I, an S, or a C? So go ahead and type that into the chat box right now. That is the end of my presentation. I will look and see what people are chatting, and I will be happy to answer any questions. Let's see. The question Dr. Selmas has is, can we have a combination between C and I types? For example, it seems I have a combination between them. Yes, let me go back to this slide right here. And yes, you can have a C-I type personality blend in that order. About 10% of the world population has what we call a cross blend. Like your first one could be a C, and then your second could be a high I type, or the D could be, the second one would be an S as well. So yes, you can have a cross blend. 90% of the time, they will follow the circle. So if you're a high D first, you will either be a C, S, I, or a I, S, C. But 10% of the time, they can go crosswise. I hope that answers your question. Let me see if I can pull up the chat again. I can't find it for some reason. Let me see if I can find the chat. There it is. Okay, it popped up. Cyan said he's an I. Yes, okay, very good. All right. Any other questions? I will turn it over to the administrator again. Again, thank you so much for having me here. I appreciate it very much. God bless you.
Thank you very much for your wonderful presentation.
Thank you.
Anyone have any questions regarding this presentation? You are welcome to ask Dr. Dave.
Okay, I have another call that I have to jump on. Thank you so much. I enjoyed speaking with you. God bless you.
Thank you very much, sir. Have a nice day. I would like to introduce our final speaker for today, Dr. Sudha Chaturvedi. Can you hear me, ma'am?
Yes. Let me share my screen.
1 second, ma'am.
Oh, I see.
Yeah, ma'am. Let me introduce you and you can start giving your presentation. Just a second.
Oh, where is my presentation?
Hello, everyone.
I don't see my presentation for some reason.
Hello, everyone. I'm introducing Dr. Sudha Chaturvedi. She is the Director of Mycology Laboratory, School of Public Health, University at Albany. Ma'am, just a second, ma'am. Let me introduce you. Then you can start sharing your screen and give presentation. Just a minute.
Okay, sorry.
Yeah. Yeah, Dr. Sudha Chaturvedi completed her PhD in medical microbiology in 1990 and her postdoctoral training on fungal pathogenesis and parasite cell biology at the University of and Yale University. Sudha Chaturvedi is now the Director of Mycology Laboratory, and she serves as a comprehensive reference facility for fungal diagnosis for all the NYS DOH licensed clinical laboratories, including hospitals, academic medical centers, county health departments, and commercial laboratories. Her research focus is to understand the molecular mechanism underlying the non-classical release of oxidative proteins. Ma'am, you can start sharing your screen and continue presentation.
Okay, let's see. I don't see my screen for some reason.
We can see your screen, ma'am.
But I don't see my presentation. Oh God, that's the reason. This is the one I want to bring it.
Yes, ma'am. You can just put it.
Oh, okay, great, wonderful. Okay. All right, can you hear me?
Yes, ma'am, we can hear you.
Okay, thank you so much, Chan, for giving me this opportunity to speak in this forum. I'm going to talk about a very rare disease, but it's a very significant disease too, called blastomycosis. Before I speak, these are my outline. I'm going to provide the background and what are the disease endemicity, how many species are involved in this disease, what are the diagnostic methods, and where we are going with the challenges of developing lab-developed tests and their implementations. So what is blastomycosis? Blastomycosis is caused by a fungus which belongs to genus Blastomyces. These are, if you see the left panel here, they are found in the environment. They like to grow in little acidic soil and they like water surrounding them. These spores are very small in size. They are less than 2 micron. When they are inhaled, they go through your nasal cavity all the way into the deeper into the lung and sits in the alveoli, and they convert there into the yeast form phase, which is shown here. And that yeast form has a very broad base budding that can distinguish these bug from another fungal pathogens. And in the very beginning, these diseases were more common in United States and in Canada. That's why they were called North American blastomycosis. Generally, the disease can be acute or chronic depending upon your immunity, but they are primary pathogens, meaning they cause infection in healthy people. Most of the time, since the infection starts in the lung, the 90% of the patient have only lung infection, but in certain cases, the infection can also go into other body parts and can disseminate into mostly bone and skin. So that happens when patient has some immunodeficiencies. So what is blastomycosis? They are being treated. They are like, if they are mild or moderate cases, the treatment is generally itraconazole, which is one of the azole drug for treating fungal infection. For if the infection is severe, then you have to change the treatment from azole to amphotericin B. And the treatment durations are very, very long. They are from anywhere from 6 to 12 months. It's just like when you treat TB patients, tuberculosis patients, the blastomycosis patients are also treated for that long. As I said before, it's a rare disease in general, but in endemic area, it can have several people, several cases per 100,000 population. The CDC has reported from 1990 to 2010, there were more than 1,000 blastomycosis related deaths. So what's the national and international range of blastomycosis? As I said before, it is very endemic in the Ohio and Mississippi River valleys, Great Lakes, as well as St. Lawrence River in the United States, as well as bordering Canada. But it is also found in some parts of Africa as well as in India. So there are many species of blastomyces. Blastomyces dermatitis was identified more than 100 years ago in 1894. And it used to be a sole etiologic agent of blastomycosis for the longest period of time. It was identified by a scientist called Gilchrist, and for the longest time, it was called North American blastomycosis. But, you know, with the recent advancement in the technology, with genome sequencing and phylogenetic analysis, there are now more than 6 species within the blastomyces genus. I will just explain some for this audience. Blastomyces gilchristii was described in 2013. That is very much closely related to blastomyces dermatitis. If you see their genome size, blastomyces dermatitis has 66.6 megabase, while Gristii has a little bigger genome of 74.5 megabase. There are other species of blastomyces, Amzentai and Pertussis. They are more common in South Africa than United States. And there are furthermore species, Silvery, Parvus, and Helicus. The last 2 species belong to Amencia genus, but now being moved back to the blastomyces genus. Blastomyces helicus, which is like rare pathogen, but when you see in this map, which has United States as well as Canada, there are only 10 human cases so far, and several canine cases. But there, if you see the pattern of their distribution, which is far away from the endemic region of blastomyces dermatitis, which is shown here in the green. And they also look very different in terms of their morphology. The upper picture shows that they make the hyphae, but they don't make that tiny spores I showed in my previous picture. This is happening in the lab, so they don't sporulate, but they definitely convert into the yeast form. And the yeast form don't only have the daughter cell and the mother cell, but it keeps budding, and they bud in kind of a chain. So which is different from blastomyces dermatitis as well as blastomyces gilchristei. So the other two species I want to talk is blastomyces percussus and blastomyces amzentii. They are mostly found in South of Africa. And they are, if you look at the phylogenetic tree on the left, they are very different from blastomyces dermatitis as well as blastomyces gilchristei. And they mostly infect human in South Africa. And the unusual feature of these particular bugs are they tend to disseminate to the skin and cause lots of pus, purulent pus. And they don't have one very special gene, which is well characterized in blastomyces BAD1, which is a major virulence factor for blastomyces dermatitis and gilchristei, but that gene is absent in these two species, which are found in South Africa. When it comes to blastomyces dermatitis and gilchristei, which I already said, they are major pathogen of North America. There are several populations known of blastomyces dermatitis as well as blastomyces gilchristei. And if you see the left figure, blastomyces dermatitis definitely is a dominant pathogen, but when you come to the lower picture, we also have several blastomyces gilchristei, and they kind of coincide with each other. They have the similar geographical region and ecological niche. And there are not that many outbreaks, but I wanted to talk about this outbreak which happened in Wisconsin. There were 90 cases were involved, and these were people who were part of the tubing cohort, and the exposure happened somewhere in the May till July of 2015, and onset started happening a month after the exposure from June till the August. And the outbreak happened, and it seems like there was a disturbance of soil and brush near river, which is shown here in the down. And this was all caused by blastomyces gilchristei. As I said before, blastomyces dermatitis is the dominant pathogen, but blastomyces gilchristei also can cause a major outbreak, and this is one example of that. So what are the major treatment options are liposomal, as I said before, amphotericin B, especially for the serious and disseminated infection, you have to treat with amphotericin B. Also, patient who has central nervous system involvement, young patient, neonates, as well as pregnant women. The azorals are also equally important for treating these patients. They are itraconazole and voriconazole. And as I said before, the duration of the treatment is pretty long. So what are the laboratory diagnoses for blastomycosis? Since I said this primary infection starts in the lung, so the sputum and bronchial wash are being cultured. Apart from that, the blood and tissue biopsies can also be utilized for the culture of organism, depending upon patient clinical diagnosis. And the culture is generally done on sabrodextrose agar with either chloramphenicol alone to inhibit all the bacterial pathogens, and also in the cyclohexamide, which inhibits other fungi apart from all dimorphic. You keep culture as 20 to 30 degrees centigrade incubators, and total time takes for culture to grow is again pretty long, which is 4 to 6 weeks. If you see on the right-hand side, the colony looks very cottony and white most of the time, and they produce small conidia, which is shown here on the right lower panel. And the size of the conidia cannot say for sure that this is a blastomyces, because there are several fungi produces the similar structure. So in order to confirm by culture method, one needs to convert this fungi into yeast form. And for that we have several medias, brain heart infusion, cottonseed agar, as well as Middlebrook broth. And the conversion has to happen at higher temperature. That requires 36 to 37, which is like human body temperature. And that convert into the yeast phase. And yeast phase, you can say for sure that that's a blastomyces. So apart from culture, we also have molecular identification methods. AccuProbe have been around for a long time, but I heard that they are going to discontinue pretty soon. The disadvantage of AccuProbe is that it only can work for the culture, whether it is mold form or the yeast form, but it doesn't work for tissues. It doesn't work for any fixed tissues. So it has a limitation. And also AccuProbe can cross-react with some other fungi, especially the dimorphic ones. So the other methods for identification are PCR and sequencing-based technology. One can use conventional PCR using ribosomal gene, and then other one is conventional PCR using BAD1 gene. And we developed in 2012 a real-time PCR assay using BAD1 gene to identify both culture as well as primary specimens. There are antigen and antibodies are available, but they are again not highly specific. If they are sensitive, they lose the specificity. If they are specific, they lose the sensitivity. So this is the assay we developed in 2012, and we used the gene BAD1. And what we have noticed was that this gene is quite, not homologous in all different haplotypes. There was lots of variation we have noticed, so we had to design several primers and probe. And at the time, we didn't have all these different blastomyces species. They used to be called haplotypes. So haplotype 1 to 3 and haplotype 4. Now we know that haplotype 4 is blastomyces gilchristei, but at the time when we developed this assay, we didn't know. Our aim was that we should be able to identify all species or haplotypes of blastomyces at the time. But later on, the year later, we had that blastomyces gilchristei. So all this variation people have seen when they were doing research, they found that blastomyces gilchristei is quite different from blastomyces dermatitis in terms of their genetic makeup. And they were now clearly defined as two different species. And there was this other paper where they have used the ITS2 gene, although there is only one SNP they have seen here in blastomyces gilchristei versus blastomyces dermatitis. But this example I'm giving have been used by several investigators to differentiate blastomyces dermatitis from blastomyces gilchristei. Can you hear me? I have a lot of sound coming. Can you hear me?
Yes, ma'am, we can hear you.
Okay. Are you seeing some disturbance in the background?
Sorry for that, ma'am. Just let me check.
No,
ma'am.
no, not you. It's my side. Are you hearing any noise?
Yes, ma'am. You are here. You are audible, ma'am. You are clear.
Okay.
Yes.
So with that in mind, we decided we will develop a new assay of real-time PCR assay where we can differentiate blastomyces dermatitis from blastomyces gilchristei. In this case, also we have used the same gene, BAD1. And as I said before, what we have found, this BAD1 gene is quite distinct in blastomyces dermatitis and blastomyces gilchristei, which is shown here. In blastomyces dermatitis, there was a big deletion in this gene. So we utilized that for designing primers and probes so that we can differentiate these two species from each other. So this assay became, we have done, anytime you develop assay, you have to look for sensitivity, accuracy, precision, etc. So assay was highly sensitive, and we our LOD was close to 1 picogram genomic DNA per PCR reaction, which is shown here on the left panel. And when you go to the right-hand panel, we have given several isolates of blastomyces dermatitis and Bilharziella, and that was blinded. That was given to us in a blinded fashion, and this assay could easily differentiate one from another. So we had 100% accuracy in the assay. Then next thing we did was we analyzed all our data with the singleplex assay we had in the past and this new assay we developed recently. So we had 78 cultures. And then which were identified initially by the singleplex assay as blastomyces species. When we used the duplex assay, what we have seen that 62 of them were blastomyces dermatitis and 16 were negative. And when we had the other probe, which was for blastomyces gilchristei, 15 were blastomyces gilchristei and the others were negative for blastomyces. If you see here, what we have noticed was that of 16, only 15 turned out to be blastomyces gilchristei. So what happened to that one isolate which didn't fall in this category? It turns out to be that was blastomyces percussus. So that also gave us a lot of confidence that our assay doesn't identify any isolates other than blastomyces dermatitis and blastomyces gilchristei. And next, what we did was we also, since the beauty of real-time PCR assay is that you can also utilize the same assay for primary specimens. So we had some 33 primary specimens which were suspected of blastomyces, and only 5 were positive by singleplex. And when we did the duplex assay, all 5 turned out to be blastomyces dermatitis, and none of them were positive for blastomyces gilchristei. So this is the recent study we have done in New York, and what we have noticed here that the blastomycosis is emerging disease in New York, because if you see 2005 versus when you see 2019 or 2017, the number of cases have gone pretty high. And the distribution seems like they are near Mohawk Valley as well as Finger Lakes, and Finger Lakes area where we have both species of blastomyces, dermatitis as well as gilchristei, while Mohawk Valley seems to have only blastomyces dermatitis. So having all these assays are excellent to have, but their implementations are quite challenging. As a public health lab, as a reference lab, we develop lots of assays, but when we want this assay to go to another lab, it's always a challenge, because any lab developed test, if another laboratory wants to use it, they must still validate them for accuracy, precision, and clinical utility. For a rare pathogen, just like blastomyces, getting even specimen is an issue for validation. Clinical labs neither have time or resource for validation. There may be marked variability between laboratories in assurance program used to monitor their performance. Instrument keeps changing, and that brings another layer of complexity. So these are always an issue for lab developed tests, although we are always more than happy to provide primers, protocols as needed for the laboratories. So in conclusion, I would like to say blastomycosis is an emerging disease in eastern upstate New York. The unclear reason for increase, there are 6 species of blastomyces. They are recognized worldwide. Of these, blastomyces dermatitis is the dominant pathogen, followed by Gilchristii in New York and North America. The duplex real-time PCR assay could be implemented in reference in public health laboratories to further understand the ecology and epidemiology of blastomycosis. Greater understanding of other species of blastomyces needed for developing rapid diagnostic tests. These are some of the people who worked in my lab for developing the assay. Jan, Chun Zhu, and Mitchell Kaplan were instrumental funding provided by CDC and National Science Foundation. Thank you so much. If you have any question, I would be willing to answer at any moment now. Thank you.
Thank you for your wonderful presentation, ma'am. Does anyone have any questions regarding this presentation? You can always ask questions or post it in the chat box, and I will forward them to our speakers and they will let you know the answers.
Thank you.
Thank you very much for your wonderful presentation, ma'am. And I hope everyone enjoyed this Public Health 2021 webinar of the first day. And I would like to invite everyone to attend day 2 presentation by tomorrow, 11 a.m. UK time. And I'm posting the Zoom link here in the chat box, and you people are always welcome to join this meeting tomorrow. And I have also sent everyone a review link, and please try to review us about our first day of the meeting. Thank you very much and have a nice day.